ऊपर से ये पार्किंग में बहुत दिक्कत करते हैं। कितने बजे? 1:55 पे इनका ख़त्म हुआ था ना। अभी ऑन है ये? रिकॉर्ड पे लगा दिया आपने? इसको ऑफ करो एक मिनट। सुबह से 3 लोगों ने लिख लिया ना लेक्चर, 2 लोगों ने, अभी तीसरा मेरा है। उनमें से एक डॉक्टर टोनी को तो कोरोना अभी हुआ है कुछ दिन पहले। ज़्यादा सिम्टम्स नहीं हुए लेकिन हुआ तो है। हमें तो अपनी प्रिकॉशंस लेनी पड़ेंगी। अभी रिकॉर्डिंग पे नहीं है ना?
नहीं, वो वाली पे नहीं, यूट्यूब वाली पे 2 जगह होता है ना।
हाउ मेनी पीपल हैव कम? अभी 83 आए हैं। The share screen is on? Share screen on है? How many students have come? लास्ट टाइम मैंने दूसरे कंप्यूटर से लिया था, उसका यूट्यूब में ना रिकॉर्डिंग अच्छी नहीं हुई थी. वो सेफ़र है बट दिस इज़ बेटर क्वालिटी. So most of you have joined. Shall we start or shall we wait for some people more to come? Good afternoon everyone. Today we are going to be taking a topic. Please, good afternoon. Once you posted your question or said something, please switch off your mics. Please put your mics on mute. Good afternoon. So I'll start with the class. Today we'll be taking a topic which is usually taken in the dissection hall. It's not a theory topic. It's about identification of structures, the regional relationship of structures to each other. That's what it is about. But because of these uncommon times, we are going to be taking it here as a didactic lecture, but I'll try to supplement it with videos so that an understanding is achieved. All right, so now that most of you are here, we can start the topic. It's a big one. Normally the understanding of relationship of structures with each other is easier because you have something to look at. So let's start by doing a revision of what we have already covered so that you have a reference point, so that you can really conceptualize how we got there, because you had a little bit of a gap between your last theory lecture, which was theory cum practical class on Saturday. So why we did the general features of radius and ulna is so that what we are going to cover today makes a bit of sense. So today our topic of discussion is cubital fossa and the front of forearm. I'll just go through what you've already covered. So we have finished the pectoral region. You have seen. Can you see my cursor? All of you can see my cursor?
Yes, ma'am. Yes,
okay. So let's just recapitulate what we did earlier so that what we do today makes a bit of sense. So this is the pectoralis major muscle, and you can see this muscle here forming the rounded contour of the shoulder. What muscle is this?
Deltoid.
Deltoid muscle, very good. And you are required, when you study muscles, by now you must know about it, that you are required to know the attachments, especially of the bigger muscles. But because you are MBBS students, nearly all the muscles of the body, so the attachments, the proximal and the distal, what we earlier called as the origin and insertion, you're also required to know their nerve supply and their actions. Right? So for any muscle you must do all these features. So we've covered the pectoral region in detail. You have seen these two muscles. You've also seen the serratus anterior muscle, which is shown here. You can also see a bit of the posterior axillary fold here. Then we covered the area what is known as axilla, and with reference to axilla, if there are any doubts about the interrelationship of structures with each other, you're most welcome to post your questions in the group, or at the end of this class you can ask. So the main neurovascular bundle of the axilla is seen here, which goes from the apex to the base of the axilla along its narrow lateral wall. So you can see that. Now we'll be making several references to many of these structures, or the continuation of these structures in the lecture today. So the cephalic vein can be seen in this figure, and you can also see the cephalic vein here. It will enter the axillary vein. Part of the axillary vein has been removed so as to expose the axillary artery and the structures related to it, the infraclavicular part of the brachial plexus with the cords of the brachial plexus and the branches of the cords seen here. And you all, I hope by now, know what is the location of the median nerve. The median nerve is easily identifiable because it is formed by two roots, one from each of the two cords, which are in the lateral and medial position in relation to the second part of the axillary artery. You've also seen this pectoralis minor muscle. The vein, the axillary vein, lies medial to the axillary artery, and you can see many other nerves as well here in this figure. And this figure also was projected to you, and I have uploaded several slides, pictures, as well as the lecture and videos in my last lecture on the shoulder region, so you can go through that after this class. And this is the posterior wall of the axilla, where I made a reference to the spaces of the scapular region, and the scapular region was also covered along with the overlapping muscles of the back. So all of you know about the trapezius, you know about the rhomboids, the levator scapulae, the supra-infraspinatus, teres minor, teres major, latissimus dorsi, and you have also covered the front and the back of the arm. So here you can see the back of the arm in this picture here, also seen here. This is the triceps muscle. So here please see this carefully, long head, and this would be the lateral head, because these two are superficial, and the medial head of the triceps is deeper, and also its attachment is to the lower half of the posterior surface of the humerus. And you can now see the spaces, the intermuscular spaces of the scapular region quite well in this figure. The quadrangular space for the axillary nerve and the posterior circumflex humeral vessels, the radial nerve and the profunda brachii artery in the lower triangular space, the boundaries you are required to know, and this is the upper triangular space which allows the circumflex scapular artery to gain entry into the back of the scapula to participate in the anastomosis around the scapula. The other participant in this anastomosis is shown in this figure, the suprascapular artery. You can see the relationship of the suprascapular nerve, which is a branch from the brachial plexus. Can anybody tell me where from the brachial plexus arises the suprascapular nerve? Anybody?
From the superior.
From the upper trunk or the superior trunk, that's right. And it passes deep to this ligament, which converts the notch into a foramen, whereas the artery passes above. And both structures pass through the spinoglenoid notch to gain entrance into the infraspinous fossa from the supraspinous fossa. So this part you have done. You have also done, I'm just recapitulating it, because in anatomy, as you will see in any part of any subject of medicine, you have to have a continuity with what you've learnt earlier. You can't do it in a limbo, you know. So we have to establish some kind of continuity with what we have done, so that what we do today makes some sense. So these are the structures of the front of the arm. You can identify what muscle is this. What muscle is this? Where my cursor is pointing? The biceps brachii. It's called biceps brachii because there's a biceps in the lower limb as well. Biceps femoris. So that's why it's qualified like that. Mostly in the popular imagination, biceps, when people say biceps, they usually mean the biceps of the upper limb of the arm. So you can see the long head emerging from the capsule of the shoulder joint, and this is the short head lying just lateral to the second muscle. What is this muscle? this coracobrachialis. Both are coming from the tip of the coracoid process. So the superficial flexor muscle of the arm, front of arm, is the biceps, and the two bellies are uniting. And lower down, now this is the area of interest for us today. You can see the tendon of the biceps going a little laterally and extending from the tendon going medially is a flattened aponeurosis, which is the bicipital aponeurosis. So the biceps inserts through a prominent rounded tendon into the radius, but it also has an indirect insertion into the ulna through the bicipital aponeurosis. So you can see that in this figure here. And you can also see an artery and a nerve, and today we'll know which artery and nerve this is. And now the biceps has been retracted slightly laterally to expose the underlying structures, the axillary structures, which at the lower border of the teres major enter the proper territory of the arm. So beyond the lower border of the teres major, the same artery which was called axillary is now called the brachial artery. So this is the brachial artery. You can see the brachial artery reaching the hollow in front of the elbow. And this hollow in front of the elbow we'll be doing today. This is known as the cubital fossa. So the brachial artery you can see here. You can see the continuation of the median nerve going down. So the median nerve is accompanying the brachial artery into the cubital fossa. You can also see another nerve here. See this one? So this nerve, which is arising from the lateral cord. We know this is the lateral cord because it is giving origin to the lateral root of the median. The medial root of the median comes from the medial cord, and the median nerve lies anterior, partly anterior to the artery, or in the groove between the artery and the vein. Fine. So the axillary vein is not shown here. So this is the median nerve going down like this. And this nerve, which is emerging, which is a branch from the lateral cord, is going laterally. It supplies this muscle which you have just named, the coracobrachialis. So this coracobrachialis, it also pierces it and then goes deep to the biceps. It lies between the biceps brachii and the other muscle in the front of the arm, this one. This is the brachialis. So you can see this nerve here. Can you see this nerve? So it supplies all the flexors, the muscles of the anterior compartment of the arm. This nerve, can you tell me which nerve this is? The musculocutaneous, correct. Very good. So the muscular part of the musculocutaneous, the territory of supply is the arm. But the cutaneous part of the musculocutaneous, by now I am sure you are aware of the fact that when we say cutaneous, we are alluding to skin, right? So the cutaneous distribution of this musculocutaneous nerve is going to be in the forearm, which is the region of interest for us today. Fine? So it supplies the coracobrachialis, supplies the biceps brachii, supplies the brachialis. So it is the motor nerve of the flexors of the arm. Arm or the brachium, the region between the shoulder and the elbow, the motor nerve supply comes from the musculocutaneous nerve, and we can see this nerve going down. And we can see that between the biceps and the brachialis, this nerve is becoming a little superficial, emerging. It will emerge along the lateral margin of the brachialis and become superficial. And it is also swinging from the medial to the lateral side. The continuation of this nerve will form the lateral cutaneous nerve of the forearm, which supplies the skin along the lateral part of the forearm, both front and back. And this figure tells you the continuation of the artery, which over the first rib was known as the subclavian artery. It is also known as the subclavian artery, where it arises within the thoracic cage. And this same subclavian artery, which comes to be known as the axillary artery, as soon as it crosses the outer border of the first rib, this axillary artery, when it goes beyond the lower border of the teres major muscle, which marks the lower limit of the axilla, the same artery is known as the brachial artery in the region of the front of the arm. And you can appreciate that is giving several branches. You are aware of the branches of the axillary artery, and you're also, because you've done front and back of arm, you may have by now read and revised or listened to in the lecture the branches of the brachial artery as well. One notable one which I will mention here, this is the profunda brachii, which accompanies the radial nerve posterior to the humerus in the spiral or radial groove, which is present obliquely across the middle of the posterior surface of the humerus. And then it comes to lie laterally. The radial nerve will also come to lie here laterally. So you can see the brachial artery going down, and in the region of interest, which is today, we will find that this brachial artery at the level of the neck of the radius, roughly at this level, although the bifurcation into its terminal branches may be higher up in the arm or lower down, that is variable. Arteries, all blood vessels show a lot of variations. Fine. Even the nerve plexuses and their branches may show variations, but it is the blood vessels which show many individual variations. But commonly the brachial artery bifurcates approximately level with the neck of the radius, beyond the elbow joint. So you can see the bifurcation of the brachial artery into its terminal branches. The one along the lateral side is known as the radial artery, and the one more medial is known as the ulnar artery. So these are the two terminal branches of the brachial artery. This bifurcation happens within the cubital fossa. Fine. And you can appreciate that there is a rich anastomosis around all joints. So there's one around the shoulder joint, there's one around the elbow joint. And elbow joint is a separate lecture, it will be covered next week. But you can appreciate that certain collateral branches are being given by the brachial artery on the medial side and by its profunda brachii branch on the lateral side, and the terminal branches of the brachial artery give recurrent branches which go and anastomose with these collateral branches in the region of the elbow. So all this is visible here. You can even appreciate one of the major blood vessels of the forearm here, which arises as a branch of the ulnar artery. This is known as the common interosseous artery, and this will divide into an anterior and a posterior interosseous branch, passing in front of and behind the interosseous membrane, which spans the gap between the radius, which is laterally placed, and the ulna, which is medially placed, being attached to their sharp interosseous borders. But you can appreciate there's a gap in the region of the proximal ends of both the bones, and the posterior interosseous artery is passing posterior to the interosseous membrane by passing above this upper margin of the interosseous membrane in the gap near their proximal ends, near the proximal ends of the bones. So all this we can appreciate from these pictures. And believe me, anatomy is learnt either by dissecting real specimens or by drawing diagrams, or a healthy combination of both. And especially true with respect to this subject, a picture is worth 1,000 words. All these pictures have been taken from the Netter's Atlas, and purposely I have not labeled them because sometimes it is difficult to identify and appreciate structures if there's too much labeling. You know, it obscures the actual figure. Try to learn anatomy, it will also be more interesting right now because you don't have access to real specimens. So try to learn it by drawing as many diagrams as you can. And the more diagrams you use to illustrate your answers, the more marks you get. So that is always the end point for a student. So in anatomy, it's really useful to be able to draw. And at least while learning, look at as many pictures, as many diagrams from standard textbooks as you can. It will help you to visualize structures better. It will give you a mental picture, something words don't always succeed in doing. So if you have a visual reference point, it's always easier to remember facts. So anatomy is factual, but It also has several visual reference points. So try to learn it like that. Okay, so now that we have done most of what we've already done, we've done a quick recap of most of what we've already covered. This is, I think, the last slide before we begin. Uh, let's talk about the compartments of the upper limb, the free upper limb, starting with the region of the arm. You are aware of the fact that the humerus, which is the bone of the arm, has its medial and lateral borders are particularly prominent in the distal half of the bone, right? Superiorly, they are not so well defined, but inferiorly, along both margins of the humerus, you can find the medial and the lateral supracondylar ridges are very prominent, right? So these are the lower parts of the medial and the lateral borders. This is the medial supracondylar ridge, and this is the lateral supracondylar ridge or line. So this is nothing but the lower prominent half of the medial and lateral borders of the humerus, and both these end in these prominences. This is the lateral epicondyle and this is the medial epicondyle, the medial being more prominent than the lateral. So this part you've already done, and you can orient yourself as to which side is medial and which side is lateral by the presence of the articular areas of the elbow joint at the lower end of humerus. The trochlea, which is pulley shaped, is medial to the rounded capitulum. Caput means head. So anything which is rounded normally is designated with names which have the word caput or this word in it. So capitulum is laterally placed, and it will articulate, as you already know, with the radial head, right? And the fossae also you have seen both on the anterior aspect as well as on the posterior aspect. So the intermuscular spaces are important. We have done this, but here you can appreciate the long head of triceps, the lateral head of triceps are superficial to the deeper located medial head of triceps. And here the lateral head has been partitioned in order to expose the radial nerve along with the profunda brachii vessels which lie in the spiral groove. And you can appreciate this here, that a little below the midpoint of the arm, the lateral intermuscular septum. So I made a reference to the medial and the lateral supracondylar lines or ridges because these give attachment to the lateral and the medial intermuscular septa, which divide the anterior and posterior compartments of the arm, right? And they are well defined only in the lower half of the arm. These septae become continuous with the fascia surrounding the deltoid. So they become prominent only inferior to the insertion of the deltoid, which is roughly in the middle of the anterolateral surface of the humerus, isn't it? So these septae are well defined only in the lower half of the arm. So here this is the humerus in section, anterior border, medial border, lateral border, and the septae, the lateral and medial intermuscular septae. These septa divide the arm into an anterior flexor compartment and a posterior extensor compartment, right? So we will see why we are talking about it in just a minute. So going back here, you can see the radial nerve pierces the lateral intermuscular septum and then comes into the anterior compartment of the arm. So the lower end of humerus, the region just proximal to the elbow joint, is important in order to understand the relationship of structures in the cubital fossa. Now this is the arm, just to orient you. This is the upper part of the arm on this side, and here you can see the bicipital aponeurosis going towards the medial aspect of the arm. So this is the neurovascular bundle. So this is the brachial artery now here, it's called the brachial artery, and this is the median nerve, musculocutaneous nerve between the biceps and the brachialis muscles, and this is on the medial side in this region, the basilic vein, which will become, some books call it brachial vein in the upper part, but most standard textbooks still refer to it as the basilic vein. So on the medial side is the basilic vein, which accompanies the brachial artery. And the brachial veins are actually venae comittantes of the artery which drain into the basilic vein. And the basilic vein continues as axillary vein beyond the lower border of the teres major muscle, right? So here we can see these structures are entering the region of the cubital fossa. So cubital fossa, the carpal tunnel you will be learning about tomorrow, and what you've already done, the axilla. These are actually on the flexor aspect of the upper limb, certain areas of transition through which structures pass. So they are very important clinically relevant areas which have been given separate names because several very important structures, notably the chief neurovascular bundle of the limb, they pass through these transit areas which are located at the junctions of parts of the limb. So at the junction of the shoulder region and the arm is the axilla. At the junction of the arm or brachium and the forearm or antebrachium is the cubital fossa, the hollow in front of the elbow. And similarly, at the junction of the forearm and the hand is the carpal tunnel. So these are important transit points. Their anatomy is surgically very important. The relationship of structures at these levels is extremely important, clinically relevant. And that's why we study them in some detail. Fine. Now this picture is actually of the back of the elbow. Today we are not going to do the dorsal aspect of the posterior aspect of the forearm and hand. That will be done on Saturday. But why I put this picture here is just to show you the parts of the lower end of the humerus and the upper end of the ulna which are subcutaneous and easily palpable, and you can actually palpate them at the back of your elbow. And a reference was made to this in the last demonstration on radius and ulna on last Saturday. So this is the more prominent medial epicondyle, this is the lateral epicondyle, and this is the posterior aspect of the olecranon process of the ulna. So these 3 points with the elbow in its proper position make an equilateral triangle at the back of the elbow. Please notice these. And when there is a dislocation of the elbow, this relationship will be disturbed, particularly when the elbow is flexed. These 3 points are the palpable parts that you can palpate at the back of the elbow. So once we've seen the anatomical landmarks, let's go on to the cubital fossa. Let's define its boundaries. So these are surface anatomy pictures to show you that this is really a depressed or a hollow area in front of the elbow. All of you can actually feel it in front of your elbow, where you have the junction of the front of the arm with the front of the forearm, right? And we describe this triangular hollow space. We describe boundaries for this space. Normally the superior boundary of this inverted triangle is defined as an imaginary line that is drawn between the 2 epicondyles of the humerus, lower end of humerus. And 2 muscles help to define its medial and lateral boundaries. And where the 2 muscles converge, that becomes the apex of this triangular area. So laterally, this is the brachioradialis muscle. Brachioradialis muscle is located at the transition between the flexor compartment of the forearm and the extensor compartment. So this brachioradialis, even though it is an extensor, it belongs to the extensor compartment and is supplied by the nerve of the extensor compartment, which is the radial nerve. It happens to cross in front of the elbow in the region of the cubital fossa. So it's a bit confusing, but that's how the structures are in the forearm. Now remember, you've already done the arm. What is the nerve of the front of the arm? We've just done a recap. Anybody? What is the nerve supply, the motor nerve supply of the front of the arm? Musculocutaneous. No, not median. Median nerve is passing through the arm, but it doesn't give off any significant branch in the arm. Even though it lies, yes, we just did it. Musculocutaneous supplies the coracobrachialis, supplies the biceps brachii, supplies the brachialis muscle. It is the motor supply to all the muscles which flex the forearm at the elbow joint, and also the biceps and coracobrachialis which flex the shoulder joint, isn't it? So musculocutaneous is the nerve of the front of the arm, the anterior compartment or the flexor compartment of the arm. And what is the nerve of the posterior compartment or extensor compartment of the arm? Anybody? So radial nerve, as far as, not ulnar, radial. So as far as the whole of the upper limb is concerned, the entire dorsal aspect of the upper limb is supplied, of the free upper limb is supplied by branches of the radial nerve. So radial nerve is the nerve of the posterior compartment of the arm, forearm as well as hand. It is the main motor supply to the muscles of the back of arm. Triceps is supplied by branches of the radial nerve. All the extensor muscles of the forearm, which you'll be doing this week, by Saturday you'll be completing that. And it also supplies, there are hardly any intrinsic muscles, there are really no intrinsic muscles in the back of the hand. So this is the nerve of the posterior compartment of the free upper limb. Whereas the median and the ulnar nerves are the nerves of the flexor compartment of the forearm and hand, the front of the forearm and the palm of the hand. This is a basic concept, that although the ventral rami only, not the dorsal rami, only the ventral rami form plexuses, right? For the upper limb we have a brachial plexus formed by the lower cervical upper thoracic nerves, spinal nerves, and for the lower limb we'll have a lumbosacral plexus formed by the lower lumbar and upper sacral nerves. So these plexuses are present where limbs are present, and limbs, because they develop from the anterolateral body wall, they don't develop from the dorsal aspect at all. So their entire nerve supply is from ventral rami branches. So the brachial plexus for the upper limb and the lumbosacral plexus for the lower limb. When you do lower limb, you'll be studying that. Have you understood this? So the entire limb, whether the ventral aspect or the dorsal aspect, is supplied by branches from ventral rami, from branches of the brachial plexus, which is formed of ventral rami. However, the rami join and form the trunks, and the trunks are in the root of the neck, right? The trunks are present in the root of the neck. The trunks then divide into divisions, and this pattern you will find in the lumbosacral plexus also. The major ventral rami which give rise to the plexus and supply the limb will first give ventral and dorsal divisions. So the ventral divisions will form the lateral and the medial cord of the brachial plexus, and the dorsal divisions form the posterior cord. So the dorsal divisions are destined, and their branches are destined for supplying the dorsal or posterior aspect of the limbs, and the ventral divisions and their branches supply whatever cords and their branches given off from the cords, they supply the ventral or the flexor aspect of the limbs. So this pattern is constant. So no dorsal ramus supplies the dorsal aspect of the limb. It comes from ventral ramus. But the dorsal divisions of the ventral rami that form the plexus. Have you understood this concept? Have you? Everyone has understood? Yes. Therefore, musculocutaneous, which comes from lateral cord is formed from ventral divisions. So is the medial cord. Can anybody tell me what ventral divisions of the trunks form the lateral cord and what ventral divisions or division forms the medial cord? Anybody?
From the ventral divisions of the upper trunk and the middle trunk
Form the
the
lateral cord.
and the
Ventral division of the
ventral
lower
division
trunk
of the lower trunk
continues as the medial cord. So,
medial cord. Yes.
right. So, the flexor aspect of the arm as well as forearm and hand will be supplied from branches either from the lateral cord or the medial cord. Does this make sense?
Yes.
Whereas
Yes.
the branches from the posterior cord, which is formed from dorsal or posterior divisions of the three trunks, will supply the dorsal or posterior or extensor aspect of the entire limb. Okay? Clear? So radial nerve is the nerve which, and also the axillary. Axillary also goes from the back, isn't it? So axillary and radial, as also the subscapular and the thoracodorsal, these are distributed to the posterior wall of the axilla, to the scapular region, and they are also distributed to the upper part of the back of the arm in the shoulder region. And radial nerve is distributed to the back of the arm, forearm and hand. That is the nerve supply. Whereas the front of the arm is supplied by musculocutaneous C5-6 from, also sometimes 7, from C5-6 mainly from the lateral cord, and the front of the forearm, all the motor supply as well as the cutaneous supply mainly, but mainly the motor supply comes from branches from the lateral and medial cord, notably the median and the ulnar nerve.
Ulnar.
So median nerve is the main nerve of the muscles of the forearm, whereas the ulnar nerve is the main nerve of the muscles of the hand, which is why the median nerve is also known as the laborer's nerve and the ulnar nerve is also known as the musician's nerve, because the hand has certain fine intrinsic muscles which are responsible for fine motor movements, skilled and fine motor movements. So because ulnar nerve is the principal nerve supply of those muscles of the hand, so it is called the musician's nerve. Whereas the forearm mainly has strong muscles with which you can do bulk work, right? They are inserted mainly in the hand. They may arise from distal part of the humerus or from the forearm bones. We'll see that in just a short while. But most of the gross bulk activities which require strength, force, are done by the forearm muscles. And because the principal nerve supply to the forearm muscles is median nerve, so it is called the laborer's nerve. Does that make sense? Does it?
Yes, ma'am. Yes.
Okay. But ulnar nerve also supplies some muscles in the forearm, and similarly median nerve also supplies some muscles in the hand. And even though both median and ulnar nerve, they pass through the arm, they give no branches, no motor branches in the region of the arm. The median nerve gives some postganglionic sympathetic branches to the brachial artery. Ulnar nerve doesn't even give those vasomotor branches, and both the nerves give some articular branches which supply the joints that they cross, notably the elbow joint. Have you understood? But apart from that, median and ulnar are not supplying any muscles in the region of the arm. Now with this basic concept, everything we do subsequently will make some sense. Fine. Okay, so we were discussing, this was a bit of a digression but an important one, so I thought I should mention. This is mainly a dissection topic, not a lecture topic. So this session is going to be a lot of discussion rather than a didactic lecture. So we were talking about the boundaries of this hollow in front of the elbow. We have defined them now. So a line, an imaginary line passing through the two epicondyles at the lower end of humerus forms the base, The lateral margin is formed by the medial surface or the medial margin of this muscle, which goes along from the lower end of the humerus along the lateral margin of the forearm. This muscle is the brachioradialis, and you are aware of this term because when you did humerus, I think it was mentioned the attachments on the lateral supracondylar ridge or line. The upper part gives origin to the brachioradialis, brachium arm to radial side of forearm, so brachioradialis, and the lower part gives origin to the extensor carpi radialis longus. You are aware of this, right? Yes? I have to check every couple of minutes whether all of you are asleep, awake, what is the status. So I keep asking questions because I don't have the benefit of looking at you people. Normally in this lecture theatre, we make eye contact with the students, so we are aware of what goes on. But unfortunately, you can see me, but I cannot see you. Anyway, so brachioradialis forms the lateral margin of the cubital fossa, whereas this other muscle that you see here, it is labeled here, the pronator teres, the lateral border of the pronator teres forms the medial boundary of the cubital fossa. And then the apex is where the brachioradialis overlaps over the pronator teres. It hides the insertion of the pronator teres, and that becomes the apex. Beyond that, the cubital fossa is continuous with the rest of the forearm. Now this picture is important, the middle one, because it shows a very important set of structures that are present in the roof. So we define the boundaries of the cubital fossa. The cubital fossa is described as having a roof and a floor. The floor is muscular, but the roof is formed by the skin, superficial fascia and deep fascia overlying the hollow in front of the elbow, right? Now running in the superficial fascia of the cubital fossa, forming the roof of the cubital fossa, is a very important vein. This is clinically a very important vein. Now you are all aware of the fact that running along the lateral side of the arm, the vein is known as the cephalic vein, and along the medial side of the arm, the vein is known as the basilic vein. Everyone is aware of this. Now this vein, which crosses over the roof of the cubital fossa, is a linking vein which is given off as a branch. Even though this is a vein, this is given off as a branch from the cephalic vein, and it unites with or drains into as a tributary of the basilic vein. This is the usual and common pattern that we find. And why is this vein very important? This vein, which is known as the median cubital vein, because it crosses the midline of the cubital fossa, median cubital vein, although it doesn't cross the median plane because the limbs are entirely lateral to the median plane, lateral to the trunk. So the median cubital vein, which links the cephalic vein with the basilic vein in the roof of the cubital fossa, is the most common superficial vein that is used for venipuncture, which means you are trying to give an IV, you are trying to draw a sample, intravenous sample, or give an intravenous injection. For short, we call it IV, intravenous. This is the vein to go to. It's superficial, it's fairly large, and as we will see with the anatomy of the cubital fossa, there are other reasons why it is a preferred vein for venipuncture, for drawing out blood samples or giving intravenous injections. So this is found in the roof of the cubital fossa. And you will find the cephalic vein here, the radial nerve lying very close to it, and whereas the basilic vein, which is accompanied by the ulnar nerve in the arm, the two digress. The basilic vein passes in front of the elbow, whereas the ulnar nerve forms a very important relationship on the posterior aspect of the medial epicondyle of humerus, where it can be palpated by rolling against the bone. This is one of the nerves which can be palpated in relation to a palpable bony landmark, the ulnar nerve. You've already done what is the relationship of important nerves to the humerus. So ulnar nerve is posterior to the medial epicondyle of humerus. You're aware of this, right? And this third figure shows you the most important contents of the cubital fossa. Laterally, the tendon of the biceps can be palpated. Just flex your elbow. Do it while you are listening. Flex your elbow. And in the hollow in front of the elbow, you can easily palpate the tendon of the biceps. Mid-flex it. Don't flex it entirely. Flex it so that it makes a 90-degree, the forearm makes a 90-degree angle with the arm. Mid-flex your elbow. The tendon of the biceps is easily palpable. Isn't it? Very easily palpable. Yes? All of you can palpate tendon of biceps in front of the cubital fossa. Now just medial to the tendon of biceps. Now this is a very important relationship. Just medial to the tendon of the biceps, the brachial artery leaves the arm and enters the cubital fossa and hence the forearm. It is just medial to the tendon of biceps. And why is this relationship extremely important clinically? It is important because it is the brachial artery, it is the turbulence in the brachial artery which is auscultated by the stethoscope when you take a blood pressure recording. What do? We tie the cuff around the arm to compress the brachial artery. And from physics you know that whenever a tube, a cylinder is compressed or there is an obstruction, a turbulence is created, right? You know about this. So we compress the brachial artery by tying the cuff around the arm and inflating the cuff of the BP machine, blood pressure machine, right? And then we release it. It is the turbulence which is heard through the stethoscope, and hearing of sounds through the stethoscope is known as auscultation. So just like feeling structures is known as palpation, hearing sounds with the stethoscope, the medical term is auscultation. So you will learn on the clinical side that these are the important parts of clinical examination of a patient. Inspection, meaning visually you see, you examine, and then palpation, you feel structures, auscultation, which means you hear sounds through the stethoscope, and finally percussion. Everyone is aware what percussion means. You tap cavities to hear sounds, whether they are resonant or whether they are solid. You are aware of percussion instruments, tabla and your drums. So percussion. So these are the 4 parts of clinical examination. Okay, so to go back to the topic at hand. So brachial artery is auscultated just medial. You place the diaphragm, that rounded circle at the end of the stethoscope. The diaphragm of the stethoscope is placed just medial to the tendon of biceps to record, to take a blood pressure reading. Because what we are listening to with our ears through the ear plugs of the stethoscope, we are listening to the turbulence in the brachial artery, which we have artificially created by compressing the brachial artery proximal to the cubital fossa. So this is clinically a very important fact, anatomical relationship. And further medial to it is the median nerve. Median nerve was lying anterior to the artery in the upper arm, in the axilla, and then in the upper arm, but then it passes in front of it and becomes medial to it in the distal half of the arm and passes into the cubital fossa medial to the brachial artery. So after having touched on these clinically relevant facts about the surface anatomy of the cubital fossa, let's look at some more pictures. So everyone can appreciate the boundaries of the cubital fossa. Everyone is clear about it. Medial boundary formed by this muscle, the most lateral of the flexor muscles that take origin from the common flexor origin on the medial epicondyle of the humerus. Excuse me. So now again we are making a reference to the distal end of the humerus, right? So you've already done this. On the medial epicondyle, there is an area of attachment which is known as the common flexor origin. Likewise, on the lateral epicondyle at the lower end of humerus, there is a common extensor origin. Everyone is aware of this? Clear? So the superficial flexors, notably the superficial flexors of the front of the forearm, take origin, or at least part origin, from this common flexor origin, which is on the front of the, or the tip of the medial epicondyle of humerus. Pronator teres also takes origin from the lower part of the medial supracondylar ridge. Yes, you are aware of this? Pronator teres was the attachment there when you did humerus.
Yes, ma'am.
Yeah. So it takes origin from the lower part of the medial supracondylar ridge and the common flexor origin. And this is the most lateral of the superficial flexors of the forearm. Right? Now brachioradialis, which is taking origin from the lateral supracondylar ridge upper part, is an extensor muscle, but the way the orientation of structures is in the forearm, it actually skirts the lateral margin of the lower part of arm and most notably the lateral part of the forearm and passes in front of the elbow joint. So this forms the lateral boundary. Its medial surface looks towards the cubital fossa. So you can say medial surface or medial margin of the brachioradialis forms the lateral boundary, and the base, the superior boundary, I have already said, through the epicondyles, line joining the epicondyles, which is an imaginary concept, right? The roof I have talked about is formed by the skin, superficial fascia and the deep fascia covering the cubital fossa, and running in the superficial fascia are two important structures. One I have already spoken about. This is the median cubital vein, a very important superficial vein for venipuncture, and the second one is the bicipital aponeurosis. This reinforces the deep fascia that defines the roof of the cubital fossa. So the bicipital aponeurosis is an extra insertion of the biceps brachii muscle, which is a flattened kind of tendon which arises from the front and medial side of the biceps tendon. You can see the biceps tendon here, and then blends with the deep fascia covering the cubital fossa, and further laterally it extends to the back of the forearm and indirectly connects the biceps tendon to the posterior border of the ulna. It extends as far back as the subcutaneous palpable posterior border of the ulna. If you remember the Saturday's demonstration, Dr. Kishore even showed you that you can actually see it with relation to a groove on the back of the forearm, the posterior border of the ulna, which is a palpable, extremely palpable and subcutaneous border, the posterior border of the ulna. Right? So this bicipital aponeurosis goes all the way up to the posterior border of the ulna and blends with the skin and the deep fascia. It blends with the deep fascia, really not the skin so much, but at subcutaneous borders of bones. The periosteum and the deep fascia, they merge with the skin. There's hardly any gap between the skin. So the whatever little superficial fascia is there is dense. It doesn't have a lot of fat. So that is very, very scanty. And the periosteum of subcutaneous parts of bones, it merges with the deep fascia at palpable subcutaneous parts of bones. Okay. So this bicipital aponeurosis goes to that direction and helps to form the roof of the cubital fossa. And the floor we will see in a little while. The contents of the cubital fossa, I have talked about three major contents. Please mute your mic. All of you, please mute your mic. Otherwise, it disturbs the class. Unless you want to ask a question. Then you can unmute yourself, ask the question, and mute it back again. Okay? So, the three important contents I've already referred to: the tendon of the biceps. Medial to the tendon of the biceps is the brachial artery and its bifurcation into the radial and the ulnar arteries, which is roughly at level with the neck of the radius, and medial to that the median nerve. These are the three important contents of the cubital fossa. There is one other content which is lateral to the tendon of the biceps. I'll just do it in just a minute. It is not shown in this diagram, so I'll just do it in a minute. And the floor of the cubital fossa is formed by muscles which are present posterior to these structures in the region of the cubital fossa. So other diagrams to show you the anatomy of the cubital fossa. Once again, cephalic vein, which will go all the way up to the deltopectoral groove. We've seen that cephalic vein in the beginning. Yeah, here. And then come to the infraclavicular fossa, pierce the clavipectoral fascia and enter the axillary vein. It's a tributary of the axillary vein, the cephalic vein. Basilic vein, which becomes continuous as the axillary vein at the lower border of the teres major muscle, right? So these same veins, they have in the region of cubital fossa this median cubital vein. This is the common arrangement, but there is variation of this arrangement. I'll just show you. Now here we can see that between the biceps brachii and the brachialis muscle, we saw in the region of the arm where the musculocutaneous nerve, after piercing the coracobrachialis, passes deep to the biceps brachii and lies between the biceps and the brachialis muscles in the arm and inclines from medial to lateral, and this will then emerge along the lateral border of the biceps brachii, pierce the deep fascia and become superficial. Forming its continuation is known as the lateral cutaneous nerve of the forearm. Supplies the skin along the lateral margin of the forearm, both front and back, and will accompany the cephalic vein in the lower part of its course. Cephalic vein is actually formed in the back of the hand. Some of you who have prominent veins, see the back of your hand. If you have prominent veins, you can see there's a dorsal venous arch. Some of the boys can appreciate better. Dorsal venous arch, very close to the heads of the metacarpals. Can you see the back of my hand? I don't know if my dorsal venous arch is prominent. It also becomes prominent with age as you lose some of the subcutaneous fat, puppy fat, isn't it? As you age, it becomes prominent. So this dorsal venous arch, the lateral end continues as the cephalic vein. Okay, so it is initially posterior to the forearm, then roughly in the middle of the forearm it comes to the anterior aspect. So this is cephalic vein. The medial end of this arch will form the basilic vein, which also comes from the back to the front of the elbow. In the region of the cubital fossa, it is anterior basilic vein, which continues as the axillary vein. So you can see this here. Okay. Now you can also see the medial cutaneous nerve of forearm accompanies the upper part of the basilic vein in the region of the cubital fossa. And what is the origin of the medial cutaneous nerve of forearm? Anybody? This is given off in the axilla. It's a branch of the brachial plexus. Which cord of the brachial plexus?
Medial cord.
Medial cord. It's the same one. Medial cutaneous nerve of arm, medial cutaneous nerve of forearm, ulnar nerve,
Yes.
median root of median. These are the branches from the medial cord. Because the whole limb is supplied by branches of the brachial plexus. The brachial plexus is formed to supply the limb. Fine, so you have to trace the distal part of those same structures. Only the muscles will differ, but The blood vessels and nerves have to go to their destination, their area of supply, isn't it? Okay, right? And the lateral cutaneous nerve of the forearm will accompany the cephalic in part of its course. See this? And now here you can see the same thing, but here, yeah, you can see the medial cutaneous nerve of forearm and the lateral. Lateral cutaneous emerges from between the biceps and the brachialis and then pierces the deep fascia, and in the region of the forearm it is present in the superficial fascia. Okay? Fine? And the medial cutaneous nerve of forearm, you can see here, is supplying the skin on the medial side, lateral is supplying the skin on the lateral side. Clear? This is the cephalic vein, basilic, and median cubital vein. Now, one of the reasons why median cubital vein is so preferred is because the median cubital vein lies superficial and therefore is supported by the bicipital aponeurosis. Not only that, the median cubital vein sends a perforating vein that unites it to deep veins in the region of the cubital fossa. So this perforating vein you can see here. So this is taken at a slight angle. So this perforating vein pierces the bicipital aponeurosis and joins the deeper veins, and therefore fixes the median cubital vein, relatively makes it stable. So the median cubital vein doesn't slip away either this way or that way when you are attempting to draw a blood sample or give an intravenous injection. Therefore, these reasons make it a preferred vein. It is superficial, it is relatively fixed in position because the perforating vein which unites it to deep veins pierces the bicipital aponeurosis, and the bicipital aponeurosis provides it posterior support, therefore, and protects the structures which lie posterior to the bicipital aponeurosis, in which are the contents of the cubital fossa, notably the brachial artery and the median nerve. These are protected from puncture. When you are attempting to do a venipuncture in the median cubital vein, it is more difficult to accidentally damage them because of the protection which is afforded by this tough aponeurotic sheet, which is the bicipital aponeurosis. And this vein doesn't slip this way or that because it is fixed in position because of the presence of this perforating vein. Have you understood? So there are three reasons why this is the preferred vein. It is superficial and therefore accessible. It's easier to access superficial veins in the upper limb because normally lower limbs are covered, isn't it? So it's easier to access for the clinician. Secondly, it is protected by the bicipital aponeurosis. Thirdly, it is relatively fixed in position. So these are the various reasons. So the anatomical basis of clinical procedures, anatomical basis of clinical conditions is what you are required to know in the first year. The exact management, medical or surgical, or the exact manner of doing those clinical procedures, you will learn through the rest of the years of your MBBS degree. This is not the time. Right now, try to understand the anatomical and embryological or histological basis of why things are done the way they are done or why certain clinical conditions happen. Clear? Okay, to go on. I'm taking too much time. So now the other structure which I said, the content of the cubital fossa, is the radial nerve. Now if we go back, the reason why I did a recap, where did we leave the radial nerve last? We left it here, isn't it? This is where we last saw the radial nerve. And I said after exiting through the lower triangular space, exiting the axilla, it comes to lie on the posterior aspect of the humerus in the spiral groove, and then where it leaves the posterior aspect of the humerus at the lower end of the radial or spiral groove, both structures, the radial nerve and the profunda brachia artery vessels, both artery and veins, they pierce the lateral intermuscular septum and pass into the anterior compartment of the lower part of the arm. And now let's see what happens to it further distally. So this radial nerve, when we do dissection, your Cunningham's manual says separate the intermuscular connective tissue present between the brachialis and the brachioradialis on the lateral aspect of the distal part of the arm. So there's connective tissue separating groups of muscles, intermuscular septal sheets separating groups of muscles. However, please understand this, the lateral intermuscular septum of the arm, which is attached to the lateral supracondylar ridge, is posterior to the brachioradialis and the extensor carpi radialis longus, which take origin from the anterior aspect of the supracondylar ridge. So the septum, the lateral intermuscular septum, is actually posterior to these two muscles, even though these two muscles are extensor muscles vis-a-vis their nerve supply. You know, when you go abroad, your mind goes with you. So your habits, your cultural condition travels with you. Isn't it? Same way when muscles travel or migrate to gain attachment to other structures, they carry their nerve supply with them. So even if you are an Indian who has lived in America for so many years or decades, you'll still have a bit of Indianness in you because your mind, your brain, and your cultural conditioning is still there inside you. Similarly, the nerve supply of muscles travels with the muscle, no matter where the muscle goes and attaches itself. And you've seen that in the region of the back. Upper limb muscles which anchor the upper limb to the back, crossing superficial to the intrinsic muscles of the back, trapezius, latissimus dorsi, carry their nerve supply with them. Latissimus dorsi notably, because it's supplied from brachial plexus. That means it has developed in the upper limb bud. So even though it has migrated so far away to overlap the intrinsic muscles of the back, it still carries its nerve supply with it. But when you emigrate, you naturally can't carry your food supply with you. You can take some food items, but they are not going to last you. So ultimately, wherever you have migrated, you have to get your food from there, right? Similarly, the blood supply of structures is from the regional arteries and drainage into the regional veins. Always remember this metaphor. Nerve supply migrating structures carry with them. Lymphatic drainage also they carry with them. But the blood vessels are from the regional arteries. Whatever arteries are nearby, they will then establish branches to supply those structures. So this is just another digression. Okay, come back. So the brachioradialis and extensor carpi radialis longus take origin not only from the lateral intermuscular septum, and because they arise from the front of the septum, they also take origin from the anterior aspect of the lateral intermuscular septum. But there is some connective tissue, a condensation of fascia, which separates the flexors of the elbow, the biceps and the brachialis from these two muscles, which are sometimes referred to as the lateral compartment of the lower arm and forearm. So brachioradialis supplied by radial nerve, also the extensor carpi radialis longus supplied by radial nerve, but lies in front of the elbow. Now when we separate this connective tissue, we can see the radial nerve which has crossed from back to the anterior compartment emerging out. And then it comes to lie in the cubital fossa. So the structures that form the contents of the cubital fossa from lateral to medial are radial nerve and its terminal branches. The radial nerve divides within the cubital fossa. It gives a superficial branch which we can see going down. It gives several muscular branches which supply these two muscles and other muscles also. and its continuation here will pass between the two heads of origin of a muscle that forms the floor of the cubital fossa, the lateral part of the floor of the cubital fossa, and go to the back of the forearm. This is the deep branch of the radial nerve, which in the back of the forearm is known as the posterior interosseous nerve. So radial nerve is the nerve of the posterior compartment of the forearm through its deep branch, which is known as the posterior interosseous nerve. So deep branch of radial and posterior interosseous, same thing. So this deep branch of radial nerve or posterior interosseous nerve goes through the floor of the cubital fossa to become posterior. So the radial nerve has pierced lateral intermuscular septum to come from posterior to anterior compartment of the lower part of arm briefly. It lies in the cubital fossa, and then its continuation, the deep branch, pierces the floor of the cubital fossa to go back again to the dorsal aspect of the forearm. Only its superficial branch will be seen in relation to the brachioradialis. It will pass deep to the brachioradialis. Between the brachioradialis and this other muscle, which takes origin from the lateral supracondylar ridge, known as the extensor carpi radialis longus, the long radial extensor of the wrist. Carpus is wrist. It is the long radial means it's on the lateral side. Extensor, it is an extensor at the wrist joint, but it is also a radial deviator or abductor at the wrist joint. Extensor carpi radialis longus. Clear? So these are the four structures: radial nerve, its superficial and deep branches, tendon of biceps, brachial artery and its bifurcation, and median nerve are the four contents of the cubital fossa. The floor is formed by the insertion of the brachialis medially, and you by now know that the brachialis inserts into the front of the coronoid process of ulna and the ulnar tuberosity present at the lower or apex of the front of the coronoid process. Yes? Let's see, I have a picture of the radius and ulna. Just to recap, yes. So this is the front anterior surface of the coronoid process of ulna, right? Anterior surface of coronoid process of ulna, and its lower edge is rough. This part, apex, is rough. This is called the ulnar tuberosity. So the brachialis inserts here. The brachialis inserts here. Okay? It arises here and inserts here. This is the origin of brachialis from the humerus. This is the insertion. Everyone is clear, or everyone has gone off to sleep and I am just talking? Is this clear? Brachialis insertion.
Yes, ma'am.
Okay. And you can also see this is lateral. So this is brachioradialis, extensor carpi radialis longus origins, common extensor origin. And here pronator teres, common flexor origin. Clear? Clear so far? We are going to be doing attachments on the front of radius and ulna today, and we'll do attachments on the back on Saturday when we do the dorsum of forearm and hand. They make more sense this way. Okay, clear? Should I proceed? So the brachialis is like this, so it forms the medial part of the floor of the cubital fossa. The lateral part is formed by the supinator muscle. And where does the supinator take origin from? You have done the supinator crest on the lateral part below the radial notch. On the lateral aspect of the upper end of ulna, there is a radial notch. Here, below that, there is a hollow to accommodate the radial tuberosity. So from that hollow and the sharp crest behind the hollow called the supinator crest. This is one attachment of the supinator muscle. The other attachment is from the common extensor origin. So these are the two origins. It passes behind the radius and ulna, and then it winds around the radius to be inserted into this part, lateral, the spread out lateral surface of the upper half of radius. Remember, the borders of radius start from below the radial tuberosity. So the anterior border, sorry, follow my cursor. The anterior border is from here to here. The introitious border is from here to here. And the posterior border will be on the posterior aspect from here to here. Isn't it? So the lateral surface is more extensive near the proximal end of the radius. So the supinator winds around the back of the proximal part of the radius and inserts into the upper part, upper half nearly, of the lateral surface, overlapping the neck anteriorly as well as posteriorly. Overlapping it anteriorly as well as posteriorly. Superior to the insertion, the rough insertion for the pronator teres. So thus the supinator forms the lateral part of the floor of the cubital fossa. Medial part is formed by the brachialis muscle. Supinator forms the lateral part, brachialis forms the medial part of the floor. And the supinator has a big insertion. Lateral surface overlaps front and back of the proximal part of the radius. Therefore, above the anterior oblique line, which forms the proximal half of the anterior border of radius, this is still called lateral surface, because lateral surface is between the anterior and posterior borders, right? And anterior surface is between the anterior and introitious border, and posterior surface is between the posterior border and the introitious border. This is for the radius. And for the ulna, the medial surface is between the anterior and posterior borders. The anterior surface is between the anterior border and introitious border, and posterior surface is between the posterior border and introitious border. Clear? Everyone is clear so far?
Yes, ma'am.
All this takes time, and it takes longer when we do it without the benefit of the dissection specimens. Okay, fine. So everyone is clear about the roof, floor, contents, boundaries of the cubital fossa? Yes? Now notice one thing in this figure. This is the pronator teres. The pronator teres has a superficial large head which takes origin from the lower end of humerus, medial supracondylar ridge and adjoining part of the medial epicondyle, which has been cut in this section. But it also has a minor slip of origin, and Dr. Kishore I think mentioned it. Going back to the attachments, there are 3 small slips of origin along the medial margin of the coronoid process. Sometimes 2. Here also you can see. Here you can see 3. Right? So this middle one. So this is the superficial head of pronator teres, the bigger one, and it gets a slip, a deep head from the medial margin of the coronoid process below this tubercle, which he called as the sublime tubercle, if you remember. So this is the deep head of pronator teres, and both heads converge towards the middle of the lateral surface of the radius. This is the pronator teres, below the insertion of the supinator. You can understand from the direction of fibers, the supinator is passing behind the radius. So if it contracts, it will pull the lateral surface in such a way that it faces more laterally. Whereas the pronator is in front. When the pronator contracts, it will pull the lateral surface to face medially. So, in other words, it will medially rotate the radius. Anything which medially rotates the radius will also cause the distal part of the radius to move over the distal end of the ulna, the movement of pronation. Clear? Clear or not?
Yes, ma'am.
This is pronator teres. Deep head, superficial head. Pronator teres. Supinator arises from here, but it goes behind the radius and inserts here. Okay? And this is the insertion of the biceps on the posterior part of the radial tuberosity. Okay. So in this figure we can see one important fact, that the median nerve leaves the cubital fossa by passing between the two heads of the pronator teres. See this? This is the median nerve. My slides today have no text. They only have pictures. Because this is all learnt by dissecting. And since we don't have dissection, so we might as well have it through pictures. That was my logic, my rationale. Okay, so median nerve leaves the cubital fossa by passing between the two heads of pronator teres. Whereas the ulnar branch of the brachial artery passes deep to the deep head of pronator teres. Clear? See this relationship? The radial branch of the brachial artery, which is also given off in the cubital fossa, is more superficial and accompanies the superficial branch of the radial nerve for a short duration. Then it passes in the groove between, lower down. There is a groove between the extensor, the lateral compartment muscles, brachioradialis and extensor carpi radialis longus, and the superficial flexors of the forearm, the pronator teres and lower down flexor carpi radialis. So the radial artery will continue here. You can see it here. Radial artery will continue here. Okay? Now we have entered the forearm. A quick revision. I am not concerned with the nerve supply of the arm and shoulder region. You've already done. Hand will be taken up tomorrow, so it will be revised. I am only going to speak about this today. The cutaneous nerve supply. Whenever we do any region, we always talk about the cutaneous nerve supply. So this PPT will be uploaded in the on the Saral platform. So if you want to revise the rest of the cutaneous supply, you can do it. You can do it from the PPT. Any clarifications you want, I am happy to tell you. But for us today, the cutaneous nerve supply of the forearm, the front of forearm, is from two nerves. The lateral cutaneous nerve of forearm, which is the continuation of the musculocutaneous nerve, which supplies the lateral half of the forearm front and partly the back, and the medial cutaneous nerve of forearm branch from the medial cord of the brachial plexus, which supplies the medial half of the front of forearm and a narrow strip of the back as well. But unlike the front, the posterior aspect of the forearm receives its cutaneous nerve supply from the posterior cutaneous nerve of forearm, which is a branch of the radial nerve. So at the back, most things come from radial nerve. So this is just to simplify. U stands for ulnar, R and M. There is a slight difference of opinion in the hand, so I thought I'll mention it. On the palm, it's 3.5 digits and 1.5 for median and ulnar. But on the dorsal aspect, it's commonly 2.5 and 2.5. Sometimes 3.5 and 1.5. So I'll just make a reference to this. Beyond that, I'm not doing. One other fact in the cubital fossa which I wanted to mention, I don't have the picture. I thought I had it. But anyway, there is sometimes a variation. Instead of this median cubital vein, there may be a vein coming down from the cephalic and one coming from the basilic, and the two uniting to form a median vein of forearm. So there's a lot of variation in the way veins are present in the roof of the cubital fossa. I don't have a picture, otherwise I would show you. Okay, so just a mention. So now you know that most of the branches of the brachial plexus, because they are from a plexus, and plexuses are formed by the intermingling of fibers coming from different spinal segments, right? So that is a mechanism to ensure that the loss of one spinal segment doesn't compromise the sensory supply to any major area. There is considerable overlap between the nerves. However, if we plot a map of the part of the limb which is supplied from specific spinal segments, that map differs from this map, because here this is the peripheral nerves, and peripheral nerves contain several nerves from several segments, and one segment distributes to several nerves. Now these dermatome maps, you know what is dermatome by now? The strip of skin or the area of skin supplied by a single spinal nerve. That's a dermatome, right?
Yes.
Now, they in the limbs, because remember the limbs. Now, can you see my hand right now? You can't see the entire limb, but can you see part of the limb in the webcam? Can you see it?
Yes, ma'am.
Okay.
Yes.
So
Yes, ma'am.
when the limbs they develop like this. There is a pre-axial border and a post-axial border. Okay. Later on, the upper limb undergoes 90 degrees lateral rotation, whereas the lower limb undergoes 90-degree medial rotation, which is why thumb is lateral and the big toe is medial in the foot. So the pre-axial border becomes the radial or the lateral border of the upper limb, whereas the pre-axial border becomes the medial or the tibial border of the lower limb. So dermatomes, the way they are organized in the limbs, because remember the brachial plexus is formed by ventral rami C5 to T1. So there are axial lines which represent junctions of discontinuous dermatomes. The consecutive dermatomes, there's a lot of overlap in supply. So that, for example, if the C5 spinal nerve is damaged, the C4 and C6 will supply, there's so much overlap that they will take over the supply of most of the skin which is innervated by C5 except just a narrow strip in the middle. There is so much overlap, okay, of consecutive dermatomes. But dermatomes do not overlap where they form junctions with non-consecutive spinal segments. And the junction of non-consecutive spinal segments are referred to as axial lines. So the axial line goes from the level of the sternal angle for the front of the limb, front of the upper limb, from the level of the sternal angle down the front of the arm and reaches almost up to the wrist, stopping just short of it, 1/3 of the forearm, it stops. So the consecutive dermatomes you can trace, remember the supraclavicular nerves supply the skin over the shoulder, root value C3, C4, right? Then this upper lateral cutaneous nerve of arm, the skin over the lower half of deltoid, is a branch from the axillary nerve. Lower lateral cutaneous nerve of arm comes from the radial. So the dermatomes are very important, you have to learn them. C3, C4, C5, C6 in this manner. C7 only in the palm, C8. So they go down the axial line and then they go up the axial line medially. Down the axial line laterally and up the axial line medially. So C8 and then T1. Why this area is T2 is because the intercostobrachial nerve, which is the lateral cutaneous branch of the second thoracic spinal nerve, second intercostal nerve, it forms a loop of communication with the medial cutaneous nerve of the arm and supplies the skin of the floor of the axilla and the upper part of the medial aspect of the arm. If you've read it, always remember whatever you have read before, learnt before, connect it up with what you are learning in henceforth. Don't have knowledge stored in separate boxes with no communication. Then it's not complete knowledge. Always refer to what you have learned before and link it up to what you're learning now and what you will learn henceforth. then only things start to make sense and they become exciting. Otherwise, it's one dull, drab mugging exercise, which really doesn't have, there's no fun, no excitement. Okay? To continue.
Ma'am, ma'am,
Yes.
then you said that we should practice by making diagrams. Did you mean like the same diagrams or the schematic ones, the simple ones?
You know, the best schematic diagrams are in Snell. The three-dimensional concepts you can get from very good diagrams, and now the text is also very good, of Students' Gray's Anatomy. Students' Gray's is also a good book now, the subsequent editions. It has been revised by an editorial board comprising of several members of our department, and the chairperson is the head of surgery department at AIIMS New Delhi, Dr. Sunil Chumbar. So now the Student Grace is a very good textbook. It wasn't to begin with because it didn't give enough theory, but the diagrams were always exceptional. So for concept formation, you can refer to Student Grace. Many of these books are, at least the older editions, for the pictures are available online. So you needn't purchase all the books. But for drawing schematic diagrams, please refer to Snell's Anatomy by Regions, Snell's textbook of anatomy, because those are the best schematic diagrams. All other books that you refer to, including the world famous BDC, has several errors. Please don't refer to that. I'm not saying Gray's Anatomy because that is too much. Refer to Student Gray's and refer to Snell. And in order to build concepts, refer to Cunningham's Manual of Dissection, Practical Dissection. It gives excellent concepts. Most of what I'm speaking so far comes from there. Some of it from other sources, but most of it from there. It's such a slim volume. If you master that, you know your anatomy. Okay,
Okay.
to go back.
Thank you so much.
Fine. So the dermatome, so a neurologist will first examine the limb, upper and lower, to see if a peripheral nerve is damaged. Then you need to have this map. But if the injury is closer to the central nervous system and specific spinal segments or spinal nerves are damaged, then you need this map. If you want to get any information by clinical physical exam, general physical examination of the patient. That's why we do this. Clear? Now the superficial veins I have mostly done. This is the other picture. Yes, I have it. So this is the other way in which you may have. So there's a lot of variation. This is the common way the median cubital vein is oriented in the cubital fossa, but this is the other manner. So sometimes there's a branch from here, and a median vein of forearm. So this pattern is also quite common. In which case this, whole thing will be referred to as median cubital vein. I better hurry up. I've already spent 1.5 hours on just the introduction. Now this we've done, I'm not going to repeat, this is just for reference for the attachment of some of the muscles which we are going to find in the forearm. And finally we come to the muscles of the forearm. Okay, so I've already referred to the fact that these muscles, these are extensors but present in front of the forearm. These muscles, which come from the common flexor origin but also from other sources, medial supracondylar ridge, may get a few slips from the forearm bones. These are the flexor muscles of the forearm. So the muscles of the front of the forearm are arranged, most books agree, in 2 layers at least, superficial and deep. But because this particular muscle is slightly deep to these muscles, most of the books will also make a reference to the fact that we should describe 3, not 2 layers. So when we say superficial flexors of the forearm, we refer to these 5 muscles, but this one is slightly deep to these 4. So from lateral to medial, taking origin from the common flexor origin, but also from other places, we'll see one by one. Lateral to medial, these are pronator teres. We've already seen pronator teres, median nerve passing between its 2 heads and ulnar artery passing deep to its deep head. and where it takes origin from and where it inserts in the middle of the shaft of the humerus, pronator teres. Next one, the radial flexor of the forearm, flexor carpi radialis. So because it is crossing the front of the elbow joint, it is a weak flexor of the elbow joint. The prime mover means main muscle causing flexion of the elbow is the brachialis. And the second in importance is the biceps brachii. These muscles which cross the elbow joint are weak flexors of the elbow as well. Whenever a muscle crosses in front of a joint, it is a flexor at that joint. Fine? So pronator teres is mainly a pronator but also a weak flexor. Flexor carpi radialis is a weak flexor at the elbow joint, but it is the radial flexor of the wrist, which means it flexes the wrist joint, but because its insertion is lateral in relation to the hand, we'll see where its insertion is exactly. It's inserted in the hand, not at the wrist, further distally in the hand. It also, when it contracts, causes what is known as abduction or radial deviation at the wrist joint. So radial flexor of the wrist, the name suggests the action, flexor carpi radialis. Now because there is only one, we don't qualify the name further. You've already heard of extensor carpi radialis longus in relation to the lateral supracondylar ridge, because there are two. So the main one is called longus and the shorter one is called brevis. Is just, but the names are suggested, names of forearm and hand muscles suggest their actions. So it's not very difficult to make out the action. Now this figure shows you how the muscles are oriented in the region of the forearm. So the anterior compartment is anterior and more medial compared to the posterior compartment, which is not only posterior but also lateral. The brachioradialis and the extensor carpi radialis longus. So some people describe it separately as a lateral compartment. So this is a transverse section showing the radius, the ulna and the interosseous membrane. But the lateral intermuscular septum, remember, is here. This is not the lateral intermuscular septum. This is an error. If it is still there, I don't know. This is an error in the student grays. This picture is taken from student grays. This picture is taken from main grays. So the pictures you will find in the PPT are from three sources. They are either from the 41st edition of Gray's Anatomy or the earlier editions, or from student grays, or from Netter's Atlas of Anatomy. Most of the unlabeled pictures are from are hand drawn pictures from Netter's Atlas. Okay. So these are the four important most superficial muscles: pronator teres, flexor carpi radialis, then this thin slender muscle which is a disappearing muscle, which may or may not be present. Only a short belly, most of it is tendinous. This is called palmaris longus. The palmaris longus is attached distally not to a bone, but it is attached to the superficial aspect of the flexor retinaculum, and beyond it, it becomes continuous with a triangular thickening in the deep fascia of the palm, which is known as the palmar aponeurosis. Again, in detail, you will study tomorrow when you do hand. Arises from the common flexor origin and attaches to the superficial aspect of the flexor retinaculum, where it becomes continuous with the apex of the palmar aponeurosis. The palmar aponeurosis is considered to be its continuation in the hand, the tendon of palmaris longus. Clear? And this is often absent, this palmaris longus. It doesn't really do much of a function, except it can make the palmar aponeurosis taut. It tenses the palmar aponeurosis, it pulls it and improves the grip in grasping objects with the hand. the skin also has to be tightened. So one function of this is that. Okay. And then the most medial muscle is the flexor carpi ulnaris, the ulnar flexor of the wrist. So you have a flexor carpi radialis, you have a flexor carpi ulnaris. Clear? So flexor carpi and these four muscles mainly from the common flexor origin. Although the pronator teres takes origin from medial supracondylar ridge and has a slip forming the deep head of pronator teres from the medial margin of the coronoid process of ulna. Okay? But the other three don't have, only arise from this common flexor origin. The flexor carpi radialis and ulnaris are inserted in the hand. We'll see where in the hand. Whereas the palmaris longus, I've already told you, continues with the palmar aponeurosis. Now, in between these tendons, you can appreciate there is another intermediate layer. This muscle is known as flexor digitorum superficialis, also known as sublimis, which is why the slip of origin it takes from the upper end of the medial margin of the coronoid process of ulna is known as the sublime tubercle. This flexor digitorum superficialis. Its main origin is elsewhere. We'll see. This is the main origin. It has a humero-ulnar head and a radial head. Flexor digitorum superficialis. This forms the middle layer. It is superficial but deeper to these tendons. So it is the superficial flexor of the fingers. It is the superficial flexor of the digits. Therefore known as flexor digitorum superficialis. The deep layer consists of one main flexor of the thumb. The thumb is referred to as pollex. So anything to do with thumb is pollicis. A main flexor, main, profound, main, deep. Deep, profound also means deep. Flexor of the digits or fingers, flexor digitorum profundus, and another pronator muscle. So you have one pronator muscle in relation to the superior radioulnar joint. You have another pronator deeply placed in relation to the inferior radioulnar joint. This is the basic organization of the forearm muscles. Let's see what else we can see here. As far as the arteries and nerves are concerned, we've already seen where the brachial artery divides into radial and ulnar. Radial is superficial. So it passes in the groove between the pronator teres brachioradialis and then emerges between the tendons of brachioradialis and flexor carpi radialis at the wrist where you palpate the radial pulse. So the filmy pulse which everyone palpates in movies, even laymen palpate, that's your radial pulse. Now, why do you palpate it here? This is because, let me go back to the bone. Yeah, the lower end of the radius, the distal edge of the lower end of radius projects anteriorly. And the lower part of the anterior border here is also sharp and very well defined. Okay, so because the bone is concave in front and convex laterally, the lower end, the anterior edge of the lower end of radius projects forwards. So when the artery is pressed against this edge or pressed laterally against the lower end or the lower part of the anterior border of radius, remember the anterior border is like this, right? It is readily and superficially palpable. So radial pulse, the pulsation of the radial artery is the most commonly palpated peripheral pulse. in order to get some information about the state of your cardiovascular system, arteries which are superficial are pressed against bones. And the pulse that you feel when you press an artery against the bone. And why is the pulse felt? Because the arteries are vessels which will also distribute the force of contraction of the heart. So that is transmitted or distributed through the arteries, isn't it? So the force of contraction of the the force of contraction of the heart can be assessed peripherally by palpating the artery, pressing the artery against a rigid structure, usually a bone. So this is your radial pulse. And the radial pulse does not give any other information. Whatever Hindi movies may tell you, you can't know the status of anything besides the cardiovascular system by palpating the radial pulse. Okay. So we can see the radial pulse here. We can also see between the tendons of the flexor carpi radialis and the flexor digitorum superficialis, which is slightly deeper, the median nerve becomes superficial again. Remember, here we left it. It passes between the two heads of the pronator teres, goes deep, it goes deep to the flexor digitorum superficialis, and then just proximal to the wrist, it emerges. So here it is fairly superficial. So in superficial injuries to the wrist, slashing the wrist, so many structures can get damaged, very important ones. The radial artery, and here you can see the ulnar artery also. The ulnar artery, which passes deep to the deep head of pronator teres and then passes also behind, posterior to flexor digitorum superficialis, inclines medially and becomes superficial proximal to the wrist between the tendon of the flexor carpi ulnaris and the flexor digitorum superficialis. Here it is accompanied by the ulnar nerve. We'll see how the ulnar nerve got here. So, whereas the wrist and hand is the territory for tomorrow's lecture, you see we have traced it up to the distal part of the forearm. So, these structures just proximal to the flexor retinaculum are fairly superficial. This is what I wanted to impress upon you. Now, this is a transverse section through the proximal part of the forearm. We are not concerned with these muscles, except maybe the brachioradialis and extensor carpi radialis longus and brevis, which help to form the lateral compartment. This is the lateral side. We are concerned today with these muscles, the front of the forearm. So we have the arrangement, the pronator teres, the two heads, the superficial and the deep head, which means, the humeral head is superficial, which arises from the medial supracondylar ridge and the common flexor origin, and the ulnar slip of pronator teres below the sublime tubercle, that's the deep head, and we can see the median nerve passing between the two heads. The brachial artery has not yet, no, it has bifurcated. So this is the ulnar artery and this is the radial artery. So the superficial muscles are these, pronator teres, then flexor carpi radialis, okay, then palmaris longus, this is the upper half, remember, and flexor carpi ulnaris. And the deep muscles, the intermediate layer, is formed by the flexor digitorum superficialis, and the deep muscles in this part of the forearm are going to be one flexor, deep flexor or important flexor for the thumb, and one for the medial 4 digits. Flexor digitorum profundus, flexor pollicis longus. This also tells you that the, this is the biceps tendon. The flexor pollicis longus is taking origin lower down. So this is in the region of the upper part of the forearm. So radial tuberosity is below this level. That's why this is the biceps tendon. That's why this is the biceps tendon. Otherwise, on the front of the radius would be the flexor pollicis longus. So because the biceps tendon on its way to the radial tuberosity That's why if you're seeing this, you cannot see flexor pollicis longus. And if you go further lower down, you can see both the deep muscles. Flexor pollicis longus, flexor digitorum profundus, and the superficial muscles as well. The flexor carpi radialis, palmaris longus has become a tendon, and this is the flexor carpi ulnaris. Pronator teres is already inserted, so you may or may not see the insertion. Yeah, here we can see the insertion into the middle of the lateral surface of the radius. So these are the two deep muscles. Pronator quadratus is not visible because it is present in the distal 1/3 or distal part of the forearm. We are not yet concerned with these muscles. Okay. So most of the attachments I've referred to. Let's go over the attachments on the radius and ulna which are relevant to our class today. That is the muscles of the flexor compartment of the forearm. So many of them in the lower end of radius we have done. So let's start muscle by muscle and trace it to its attachments. That's the better way of learning attachments. So the most lateral flexor pronator teres from here, and one slip from here. That is your pronator teres. This is the humeral head. This is the ulnar head of pronator teres. Okay. Superficial and deep heads, this is its insertion, middle of the lateral surface. There's a rough area. Sometimes it is called the pronator tubercle. It's so rough and well defined. Pronator teres. Next, flexor carpi radialis, common flexor origin, and it goes into the hand. It is inserted into the bases of the second and third metacarpals. Flexor carpi radialis, bases of the second and third metacarpals. Next, palmaris longus, no bony attachment except proximally, which is at the common flexor origin. Next, flexor carpi ulnaris. Flexor carpi ulnaris is attached not only to the common flexor origin on the medial epicondyle of the humerus, but it also has an attachment on the medial surface. Now it is not shown here, on the medial surface of the olecranon process. Flexor carpi ulnaris also has an attachment on the medial surface of the olecranon process, and it also gains attachment via a long aponeurosis to the posterior border of the ulna. The posterior border of the ulna, which is subcutaneous, has a long aponeurotic attachment which is formed by the intermingling of the aponeuroses of three muscles. The bicipital aponeurosis from the biceps brachii, flexor carpi ulnaris, and later on you will learn extensor carpi ulnaris as well. So flexor carpi ulnaris blends with the upper half of this posterior border. Extensor carpi ulnaris in the middle 1/3, and the bicipital aponeurosis in the upper part to the posterior border of ulna. That is the proximal attachment of the flexor carpi ulnaris. One superficial head, humeral head from here, and another head from the medial aspect of the coronoid process and posterior border of ulna. The ulnar nerve, which went behind the medial epicondyle, passes between the two heads of the flexor carpi ulnaris to come to lie in the anterior compartment, medial side of the forearm. And the flexor carpi ulnaris will go down and insert into this bone here, carpal bone here. I have another picture to show you all the carpal bones. So this carpal bone which is P-shaped, which is a sesamoid bone in the tendon of flexor carpi ulnaris, is known as pisiform. P-shaped, pisiform. This is pisiform. So we say either that the flexor carpi ulnaris is attached here, and Beyond the pisiform, the distal part of the tendon of flexor carpi ulnaris forms two ligaments. One goes to the base of the fifth metacarpal, piezo-metacarpal, and one goes to the hook of the hamate, piezo-hamate ligaments. These are considered to be the distal part of the tendon of flexor carpi ulnaris, in whose tendon this sesamoid bone called pisiform lies. This will be repeated tomorrow in the hand. But since we are doing muscles of the forearm, I thought it's always a good idea to follow a muscle from its proximal to distal attachment, instead of trying to mug up attachments without any interrelation with each other. This is a better way of learning muscle attachments. So the superficial flexors are done. Let's see the flexor digitorum superficialis. Where does that arise from? The flexor digitorum superficialis has a humero-ulnar head arising from the common flexor origin and this sublime tubercle together like this, and also from the ulnar collateral ligament in this position. So this is the humero-ulnar head of the flexor digitorum superficialis. The second head of this muscle is along the anterior oblique line, which is the upper part of the anterior border of radius. This is the radial head. So radial head and humero-ulnar head. The muscle breaks up into 4 tendons in the distal part of the forearm, passes in the carpal tunnel, which you will be studying tomorrow, and inserts in a complicated way, I'll show you how, into the sides of the middle phalanges of the medial 4 digits. Flexor digitorum superficialis. The deep layer consists of one main flexor for the thumb, one main flexor for the lateral 4 fingers. Medial 4 fingers. The flexor pollicis longus, the long flexor of the thumb, because there are short flexors in the hand, which you will do tomorrow. So it becomes complicated in that order. Shoulder pectoral region is the easiest. Scapular region is tougher. Axilla is tougher. Then you have a brief respite in the arm. It is not so tough. Forearm is a little more complicated, and hand is the most. So okay, brace up. You are just beginning your journey. Okay, so flexor pollicis longus takes origin from the upper 2/3 of the anterior surface of the radius and the adjoining part of the interosseous membrane. Flexor pollicis longus. And it passes always the long flexors and extensors of digits, both in hand and in the foot. They insert into the corresponding surfaces of the bases of distal phalanges of their respective digits. Does it make any sense? So the long flexor tendon and the long extensor tendon of the thumb and the fingers goes to the base of the distal phalanx, always, whether it is in the hand or in the foot. The flexor will go to the flexor or anterior surface of the base of the distal phalanx of thumb for flexor pollicis longus, and for the medial 4 digits for the flexor digitorum profundus. So the insertion of flexor pollicis longus is into the flexor aspect of the base of the distal phalanx of the thumb and of the flexor digitorum profundus, which arises from the upper 3/4 of the anterior and medial surfaces of the ulna, shaft of the ulna. The origin may extend to the medial aspect of the coronoid process as well, even up to the olecranon, may go up. Doesn't usually go up to olecranon, but it goes up to the coronoid process, medial aspect. So this is your flexor digitorum profundus origin, and then it splits into 4 tendons. Each goes to the flexor or anterior aspect of the base of the distal phalanx of the corresponding digit. This is the insertion of the flexor digitorum profundus. There is one other deep muscle. Let's see the attachment. Pronator quadratus is a quadrilateral muscle placed deeply in the forearm, takes origin from a ridge in the distal 1/4, distal quarter of the anterior surface of the ulna, very close to its anterior border, and inserts into the distal quarter or the lower 1/4 of the anterior surface of the radius. So the insertion is, so this is a quadrilateral transverse muscle. So its insertion is more extensive than its origin on the ulna. Not only does it insert here, but if you remember, there is a triangular area, Saturday's demonstration, above the ulnar notch on the medial aspect of the lower end of radius. So into that, the deep fibers, they insert here into that triangular area as well. The interosseous border reaches that little triangle above the ulnar notch on the lower end of, medial aspect of lower end of radius. So this is as far as the attachments on the bones for the flexor muscles is concerned. One other muscle I will refer to, although it's not a flexor, because we have done the origin brachioradialis, it is one of those few muscles which originate very close to the joint on which they act, but insert far away from that joint. Most muscles originate far away and insert close to the joint on which it acts, on which they act. That is why the distal attachment of these muscles, the tendon, is the more mobile part of the muscle, and so it is called insertion. And the proximal attachment, or the proximal, also called origin, is the more relatively more fixed part of the muscle attachment. And such muscles which originate, which is majority of the muscles in the body, majority of the skeletal muscles in the body. I think I mentioned this term but did not explain it in the locomotor lecture on muscles, because at that time there was no reference point. So such muscles which originate far away from the joint on which they act but insert close to the joint, majority of the muscles are like this, are known as spurt muscles. So biceps, brachialis, these are spurt muscles. Whereas brachioradialis originates very close to the elbow joint but inserts far away from it. It doesn't cross any other joint. It inserts into the base of the styloid process of the radius. Brachioradialis. Base of the styloid process of the radius. Such muscles are known as shunt muscles, and although it is a weak flexor because it crosses the elbow joint, its most notable action is to stabilize the elbow joint, to approximate, so muscles which act in line with the length of the bones. When they insert far away and originate close to the joint of action, they approximate the articular surfaces together. They keep them together during action at those joints. Such muscles are known as shunt muscles. Brachioradialis is a prime example, a typical example of a shunt muscle. Extensor carpi radialis longus I am not doing, and brevis and other extensors, they take origin from the lateral epicondyle but swing to the posterior aspect of the limb and insert on the dorsal aspect. So I am not doing it today. Okay. Now let's take up one muscle at a time. On the radius and ulna we have seen the attachments. So this figure is not relevant today because these are the extensor muscles. We are not doing it today. So let's take up one muscle at a time, starting with the superficial layer. This part is a little difficult first time, but once you get the hang of it, it's not so difficult. Okay, so pronator teres, this is now revision. Whatever I have done, you will now see pictures of those muscles and trace those fibers. So this will help you to remember them. Pronator teres, the most lateral of the superficial flexors, taking origin from the medial supracondylar ridge and adjoining part of the uh, medial epicondyle of humerus, common flexor origin. This is the humeral or superficial head of pronator teres. Pronator teres. The deep head takes a slip from the medial margin of the coronoid process of ulna just below the sublime tubercle. So below the origin of flexor digitorum superficialis. The median nerve passes between the two heads. The ulnar artery passes deep to the two heads, deep to the deep head, and the pronator teres is inserted into a rough area middle of the lateral surface of the shaft of radius. It is when it contracts, it will cause the lateral surface to look more anteriorly, isn't it? So it's a pronator. So the radial head will just swivel in the proximal radioulnar joint, right? But at the lower radioulnar, just a minute, I'll show you. This is what happens. These pictures will explain better than I can explain. You know, words have limitations. So this is the pronator teres. Okay? This is from Netter's Atlas and this is from Student Gray's. So you can refer to these diagrams at least. So this is the humeral head, superficial head of pronator teres, deep head of pronator teres, insertion of pronator teres, right? So when this muscle shortens, what will it do? It will cause the lateral surface to look more anteriorly. That means it medially rotates the radius. So when it medially rotates the radius, at the proximal radioulnar joint, the head will just spin within the annular ligament. You are aware of the fact that the proximal radioulnar joint has an annular ligament attached to the anterior edge and the posterior edge of the radial notch on the medial aspect of the ulna upper end coronoid process. There is an annular ligament which is attached, ring shaped. Okay, next couple of lectures, an Ackland video shows it beautifully. I'll show it to you also. So this here it will just rotate, spin. But at the lower end, when this happens, the lower end of the radius at the distal radioulnar joint will actually move across the lower end of the ulna. And the ulna is stationary in this movement. So this is how pronation happens. The pronator teres is acting. Now at the distal, now this is a deep muscle, but because the action is common, so I'm just mentioning it here. Now here this deep muscle pronator quadratus is taking origin from that little ridge here on the anterior surface of ulna and has a much wider insertion on the lower end of lower 1/4 of the lower of the anterior surface of the radius, right? When it shortens, it will do the same thing close to the lower end, cause the lower end of radius to move around the ulna. The ulna is stationary, but the radius is moving along an axis which passes through the midpoint of the radial head above and the midpoint of the ulnar head below. This is the movement of pronation. And these two muscles bring it about. And therefore, both superior and inferior radioulnar joints are known as pivot joints. Actually, it is considered to be one pivot joint, wherein the pivot is the stationary ulna, is the pivot, around which the lower end of the radius rotates at the inferior radioulnar joint and spins at the superior radioulnar joint. Now it's clear? Is it clear now? Somebody had a question about pronation. Is it clear now? I think I preempted your question. I hope it is answered now. Okay. So pronator teres. We come back to the superficial layer. Next muscle, flexor carpi radialis. origin from common flexor origin, no other origin, and insertion in the hand. Where in the hand? Bases of the second. You know, digits are numbered from lateral to medial. So this is the first digit, the thumb. This is the second, this is third, this is fourth, this is fifth. The metacarpals are also named. Accordingly, they form the hand proper. The carpals form the wrist. The flexor retinaculum is attached. So the joint is proximal. This is the wrist joint between the lower end of radius and these lateral two bones. This is the scaphoid, this is the lunate. And then more medially is the triquetral, and the triquetral on its ventral aspect has the pisiform, which is a sesamoid bone in the tendon of flexor carpi ulnaris, the distal part of the tendon being represented by these two ligaments. Clear? So let's name these carpal bones, because references will be made today as well as tomorrow to these carpal bones. Hand is tomorrow morning, 10 to 12. So this is proximal row, scaphoid lateral to medial, scaphoid, lunate, triquetral, and pisiform on its anterior aspect. So pisiform is not there dorsally, it's only ventrally. And the distal row, trapezium, trapezoid, capitate, because it has a rounded head. Anything with a rounded head, caput, capitate, and hamate, because it has a hook. Hamulus means hook. So on the ventral aspect it has a hook of the hamate. And the pisohamate ligament attaches to the hook of hamate. And the piso metacarpal goes to the base of the fifth metacarpal. But we are doing flexor carpi radialis. Where does that go? It goes to the bases of the second and the third metacarpal bones. After passing through the flexor retinaculum, not shown in this diagram, which is, remember, the flexor retinaculum is here, not here. It's not here, it's here. Because this crease that you see here corresponds to the wrist joint. The joint between the distal end of the radius and the lateral two carpal bones, scaphoid and lunate. Notice the ulna is separated from triquetral by the presence of this triangular fibrocartilaginous disc. So the ulna does not participate in the wrist joint formation, which is why during pronation and supination the hand moves with the radius, and the wrist joint is also referred to as the radiocarpal joint. Radiocarpal. Now here it is different. When you do lower limb you will realize elbow, both radius and ulna articulate with the humerus, and wrist only radius articulates with the carpal bones. In the lower limb it's the opposite. Only tibia articulates with the bone of the thigh femur at the knee joint, and both tibia and fibula articulate with the first tarsal bone talus at the ankle joint. Okay? Just by the way. Okay, so coming back, flexor carpi radialis. So where is the flexor retinaculum going to be? It is attached to the two lateral and the two medial carpal bones, one each on either side from the proximal and distal row. So tubercle of scaphoid, and there is a ridge on the trapezium, laterally and medially to the pisiform and to the hook of hamate. This is where the flexor retinaculum will be. Tomorrow you will do it in detail. So the flexor carpi radialis as well as, flexor carpi radialis passes in this little tunnel which is formed between the ventral or anterior concavity of the carpal bones and the flexor retinaculum, which is attached to the lateral and medial margins of this area, which is therefore referred to as carpal tunnel. And you will study this tomorrow. Carpal tunnel. Is anyone aware of carpal tunnel syndrome? It refers to the compression of the median nerve in this location because there is a cramming of structures, long tendons, flexors from the forearm going into the hand, and very important structures, notably the median nerve. So median nerve tends to get compressed. So that symptoms that are happen as a consequence of that is called together carpal tunnel syndrome. Okay. Now come back to this palmaris longus. I have already told you it is attached to the superficial aspect of the flexor retinaculum and becomes continuous with the apex of the palmar aponeurosis. This is palmar aponeurosis, which also splits into four for the medial four fingers. It will go into each. How it will go, you will learn tomorrow. Okay, fine. So no bony attachment distally for palmaris longus. Flexor carpi ulnaris, I have told you, this is the humeral head from the common flexor origin, and the ulnar head from the medial aspect of the olecranon and coronoid and also posterior border of the ulna. And the ulnar nerve which passed into the posterior compartment from the axilla in order to groove the medial epicondyle or is related to the medial epicondyle posteriorly, now will enter into the front of the forearm, because remember it's a nerve of the front of forearm and hand, not back, through or by passing between the two heads of the flexor carpi ulnaris. And the flexor carpi ulnaris tendon has a sesamoid bone pisiform and its distal attachment through the piso-metacarpal, piso-hamate ligaments going respectively to the base of the fifth metacarpal and the hook of the hamate I have already told you. So that is the attachments of the superficial flexors. Now here this picture I have put so that you can have a look at the interosseous membrane. The radius and the ulna are linked to each other through this tough membrane. The direction of fibers passes downwards and medially, and it has an aperture at the lower end through which anterior interosseous vessels will pass to take place in the anastomosis around the neck, anastomosis around the wrist, and this oblique cord you may have done in your lecture demonstration on Saturday. This is attached from the lateral margin of the coronoid process of the ulna and ulnar tuberosity to below the radial tuberosity. This is the ulnar tuberosity, which is at the apex of the anterior surface, triangular anterior surface of the coronoid process of the ulna. And brachialis inserts here, biceps inserts into the posterior part of this. This oblique cord unites the two bones. Function is not very clear. And this is the gap above the interosseous membrane through which posterior interosseous nerve and vessel, posterior interosseous artery vessels will pass, not nerve. Nerve has already entered by passing between the two heads of origin of supinator muscle. So we have understood the attachments of the pronator teres. All these attachments you will find in whichever book you choose to read. So I did not find any point in writing them here. It is more important to understand the attachments so that you have a picture in your mind when you learn the attachments, right? Now this is another figure. This is a magnified view of the hand to show you the carpal bones. The proximal row, once again from lateral to medial, scaphoid, this is the tubercle of the scaphoid, lunate, triquetral and pisiform on its ventral aspect. Now here the hand is like this, not like this, not like this. So adjust. And these are the distal row bones, trapezium, trapezoid, capitate and hamate. And the hamate has a hook. Okay. Ignore the attachments of muscles you haven't done so far and refer to only flexor carpi radialis inserted into the bases of second and third metacarpals and the flexor carpi ulnaris on the pisiform distally continuing as piso-metacarpal and piso-hamate. It's not shown here. on the hook of the hamate. This is the hook of the hamate. The rest of the attachments please ignore for now. Are you clear with the attachments of the superficial flexors? Any questions before I go on to the next lot of muscles? Is it clear? Yes? Anybody? Everyone has gone off to sleep?
Yes. Ma'am, both biceps and supinator muscles bring about supination. So
Biceps is a powerful supinator. Supinator muscle is an adjunct supinator. The prime mover of supination is biceps.
biceps will enter between both the bones and supinator will move laterally.
No, no, no. See, supinator is an extensor muscle. So I am not doing details of supinator today. But see, the supinator will cause the lateral surface to look posteriorly because of the direction in which it is oriented. I'll try to show you in this transverse section. This is the distal half, so we can't see it. Yeah, here. See. This is the origin of the supinator from the supinator crest and from the hollow in front. Right? This is the biceps tendon is going towards the radial tuberosity. Okay? So this is the origin and this is the insertion on the entire big lateral surface of the radius, which is quite big proximally. This is supinator muscle. Right? This is supinator. So if this shortens, what will it do? It will pull the lateral surface in this direction, in the direction indicated by my cursor. Clear? So what will it do? It will cause the anterior surface to look forwards and the lower end will also be pulled laterally. The biceps tendon, by virtue of the fact that it inserts into the posterior part of the radial tuberosity. Let's go back to biceps tendon.
Yes, ma'am, I got it.
You got it? So biceps tendon, because it is inserted here, when it shortens, it will also pull the anterior surface to face anteriorly. What is known as lateral rotation of the radius. In other words, in the forearm, supination. So biceps is the prime mover of supination. Supinator helps the bicep supinate. Okay?
Yes, ma'am.
Now we come to flexor digitorum superficialis, which forms the intermediate layer. The superficial muscles I hope are clear. Now this is what flexor digitorum superficialis looks like. So it has a humero-ulnar head and it has a radial head. When you see the picture, it makes a lot more sense, doesn't it? So the humero-ulnar head of the supinator. Now in this picture you can see the annular ligament. See this? Annular ligament. So it forms a ring. It is attached to the anterior margin and the posterior margin of the radial notch on the lateral aspect of the ulna. You see in the radial notch, isn't it? I don't have the pictures for that. I have the PPT, but right now it will take a lot of time if I do that. You remember from Saturday, the radial notch on the proximal part of the ulna, isn't it? Yes?
Yes.
So the annular ligament is attached in front and behind and it kind of embraces the radial head and part of the neck also. So at the superior radioulnar joint, the head of the radius just moves like this within the annular ligament and along the notch which is medially present. Right? Okay, now go back to flexor digitorum superficialis. This is the humero-ulnar head. Taking origin from the common flexor origin, the ulnar collateral ligament, and from the sublime tubercle, which is on the medial margin of the coronoid process. And this is the radial head, taking origin from the anterior oblique line, which is the proximal part of the anterior border of the radius. The two muscles come together, I mean the two bellies come together, the two origins. This is the belly. which splits into 4 tendons distally. Now notice one thing. The median nerve passed superficially between the two heads of the pronator teres, and the ulnar artery passed deep to the deep head. That is in relation to the pronator teres. Further deeply, both structures, the median nerve and the ulnar artery, pass deep to this arch which stretches between the radius and ulna, between the two origins of the radius and ulna. So this is this arch, you see, this is stretching between the radial origin and the humero-ulnar origin of the flexor digitorum superficialis, and both these structures pass deep to or posterior to flexor digitorum superficialis. And then later on, the median nerve will go laterally and emerge along the lateral border just proximal to the flexor retinaculum at the wrist, whereas the ulnar artery will emerge along the medial border in the distal half of the forearm. And if you remember clearly, the flexor carpi ulnaris, a superficial muscle, between the two heads, the ulnar nerve which went behind the medial epicondyle comes to the front of the elbow and then goes along the medial margin of the forearm, lying medial to the ulnar artery. So the two structures come together in the distal half of the forearm. Both these structures will pass superficial to the flexor retinaculum into the hand. Distal part of this tomorrow. Whereas the median nerve passes deep to the flexor retinaculum. The flexor carpi radialis also passes deep to the flexor retinaculum. The palmaris longus bends superficial to it. Flexor carpi ulnaris is medial to flexor retinaculum. So what is passing deep to flexor retinaculum? Flexor carpi radialis, so far among the muscles we have done so far. The median nerve, the flexor digitorum superficialis, and in the next couple of slides you will see the deep flexors of the thumb or the long flexors of the thumb and the fingers. Flexor pollicis longus and flexor digitorum profundus. So this is a very narrow zone with a crowding of structures, which is why median nerve is liable to be compressed in case there is a swelling of the synovial sheaths around the tendon, or in case of arthritis, or in case of any trauma which leads to any kind of fluid collection in this narrow constricted zone. So this relationship is important. Now we have seen the origin, this tendinous arch stretching like this. So, and we also know the two heads of the flexor digitorum superficialis. Then it breaks into 4 tendons, but the tendons, these 4 tendons are destined for the medial 4 digits, but the arrangement of tendons in the proximal to the wrist is something like this. I don't know if you can see it, my hand. Can you see it? So the tendons for the middle and the ring fingers, thumb, index finger, middle finger, ring finger, normally the ring is worn here, the engagement ring in any case, and the little finger. These are the names: thumb, pollex, index, index finger or indicis, middle finger, medius, ring finger, annularis, little finger, minimus, okay, or minimus. So these are the names given to these fingers, okay. So the tendons for the middle and the ring fingers will pass anterior to those for the index and the little finger through the carpal tunnel and will splay out later in the hand proper, in the region of the metacarpals. Metacarpals form this part of the hand. Phalanges form this part, the digits. Okay? Clear? Is this clear so far?
Excuse me, ma'am.
Yeah.
Even among the muscles which we studied just now as a part of forearm, for instance,
Front of forearm.
flexor
Flexor compartment of forearm.
ulnaris flexor digitorum
Superficialis.
Even all these have got two heads, right? So why aren't they called biceps?
Because if we have so many biceps, we won't know which one it is. It is by convention. The first one they found, they called biceps. Now they can't call the subsequent ones biceps. So most of the muscles of the forearm and hand, see, names are given by human beings. They are not ordained by God, right?
Yes,
We
ma'am.
name each other so that we know who we are talking about. Similarly, we name muscles. So in the order in which they were found, they were given names. So in the forearm, it was realized it's better to give them names as per their actions. That's why. So
Fine, ma'am.
because
Thank
this
you.
muscle is the superficial and the less important flexor of the digits, it is called flexor digitorum superficialis. And we'll see how it is superficial in just a minute.
Ma'am, and these muscles are flexing the digits, right?
See, because the flexor digitorum superficialis has a humero-ulnar head passing along the medial aspect of the elbow joint. It has a very minimal or next to no action at the elbow. It takes origin from the forearm bones mainly, isn't it? And then it crosses the wrist. So it flexes the wrist. Any muscle which crosses a joint will act on that joint. So there are other flexors for the wrist, flexor carpi radialis and ulnaris, which mainly flex the wrist or cause abduction and adduction at the wrist, radial deviation and ulnar deviation. This will flex the wrist. It will also flex the metacarpophalangeal joints. Carpometacarpal, there's hardly any action. There's only little bit of gliding, sliding. It will also flex flexor digitorum superficialis because it is crossing over the metacarpophalangeal joint, will also flex the metacarpophalangeal joint. And because it is inserting into the middle phalanx, the sides of the middle phalanx, it also crosses the proximal interphalangeal joint, so it will also flex that, but it will have no action on the distal interphalangeal joint. Clear?
Yes, ma'am. So they are flexing the elbow joint as well as the
No,
what is
on
it?
the elbow joint it doesn't have much of an action because it's a very
Okay, yes.
minor origin. See, and that too on the medial side. And that too, it's a tendinous origin. Notice it is a tendinous origin. The origin is usually fleshy but may be tendinous. Even biceps has tendinous origins, both long head and short head. Particularly the long head is a long tendon. Usually muscles insert through tendons, but several muscles may arise through aponeurosis or tendons as well. And wherever a muscle is attached through aponeurosis or tendon, that part of the bone is rough. If it is attached through fleshy fibers, that is relatively smooth, not absolutely smooth. Absolutely smooth is only the articular surface. Okay?
Ma'am, and an example for such a muscle that attaches through fleshy fibers will be
Pectoralis, deltoid,
okay.
fleshy, more or less
Thank
fleshy.
you.
Yeah, lots of them. There are lots of them. Subscapularis, supraspinatus,
Yes,
infraspinatus,
that's what
teres major,
on the
minor.
tubercle.
They are all
Thank you,
fleshy.
ma'am.
Okay,
Thank you.
so come back. So now it is passed through the carpal tunnel, and now what it does, please notice here. What does it do? The flexor digitorum superficialis tendon near the head of the proximal phalanx, close to the proximal interphalangeal joint, it splits into two. It may happen even at the base of the proximal phalanx, close to the metacarpophalangeal joint. It splits into two. This is a side view. See, it's splitting into two. But you know, the splitting of fibers is not simple like this, the way it is shown. So it splits into two, then each one of these also splits into two. One set interdigitates inferiorly and one goes straight. And then this is how it inserts. I don't know if you can see. To the
Yes, ma'am.
sides of the middle phalanx. So it will act, it will flex There are other muscles acting on the wrist joint. It will flex the metacarpophalangeal and the proximal interphalangeal joint. And passing in this hammock-like splitting prior to insertion of the flexor digitorum superficialis tendon, what passes through it is the deeper tendon of flexor digitorum profundus on its way to the base of the distal phalanx. Fine? This you will repeat in the hand. But these are forearm muscles. So it is useful to follow them all the way to their insertion. So the flexor digitorum profundus will in addition also act on the distal interphalangeal joint. Yes? In addition to what the superficialis does. In addition to wrist, carpometacarpal, metacarpophalangeal, proximal interphalangeal, it will also act. It will also flex the distal interphalangeal joint. Is this clear? Many people are starting to leave. Is this clear? Yes? Okay.
Yes, ma'am.
So, and where will it insert? On the flexor, anterior aspect of the base of the distal phalanx for the profundus tendon, and sides of the anterior aspect of the middle phalanx for the superficialis tendon. So we've done the intermediate layer. Let's go to the deep layer. Now deep layer consists of three muscles, notably these two long flexors, one for the thumb and one for the digits, and one quadrilateral muscle, pronator quadratus, which is the deepest of all. See, the location wise it is the deepest. See this in this figure? These two are from netters, this is from student grays, and this is from main grays. I think this is not from 41st edition, this is from the 39th or 40th edition, because the new edition gives it more sharply defined. So here the flexor digitorum, first let's do the flexor pollicis longus. The flexor pollicis longus arises from the upper 2/3 of the anterior surface of the radius and adjoining part of interosseous membrane, and it passes into the hand deep to the flexor retinaculum, crossing the wrist joint, crossing the carpometacarpal joint of the thumb, crossing the metacarpophalangeal, and because the thumb has only one interphalangeal joint, it has only two phalanges, all the way to the flexor or the anterior aspect of the base of the distal phalanx of the thumb, acting on the interphalangeal joint of the thumb. There is no superficial, there are only two phalanges in the thumb. There is no middle phalanx, there is no proximal interphalangeal joint, and there is no superficial flexor. But this is flexor pollicis longus, so there is going to be a brevis in the hand. Okay? Not yet, not today, but tomorrow. Okay? So flexor pollicis longus. Flexor digitorum profundus. So let's look at the bones once again, just to revise where they come from. This is flexor pollicis longus, and this is flexor digitorum profundus. From the anterior and medial surface, upper 2/3, no, upper 3/4. This is from upper 2/3, this is from upper 3/4 of the ulna, adjoining part of the interosseous membrane, origin going all the way to the medial aspect of the coronoid process. This is flexor digitorum profundus. So both the deep muscles arise from the two forearm bones. They don't act on the elbow joint. They cross the wrist joint, act on the wrist joint. They cross the intercarpal, carpometacarpal, and also in case of digitorum the metacarpophalangeal in both, and in case of digitorum the proximal and distal, interphalangeal. In case of pollicis or thumb, only the interphalangeal joint, acting as flexors at all these intervening joints. It splits into 4 tendons in the distal half of the forearm, and they lie horizontally, unlike the flexor digitorum superficialis. They lie horizontally. They pass deep to the flexor retinaculum and insert into the bases, flexor aspect, anterior aspect of the bases of the distal phalanges of the medial 4 digits. Pronator quadratus we have already done. Now what is left is what happens to the structures deeply, which we have seen up to the plane of the flexor digitorum superficialis. What happens to these structures? The nerves and the vessels. So ulnar nerve we saw, this is how it comes into the front of the forearm. Clear? It's clearer in this diagram. We have traced the median nerve and the ulnar artery passing behind the flexor digitorum superficialis, lying between the profundus and superficialis is the ulnar artery, and it will go medially, join the ulnar nerve in the distal part of the forearm. Both structures can be palpated just lateral, particularly the nerve, just lateral to the pisiform bone, lying between the pisiform and the hook of the hamate. Both structures pass superficial to the flexor retinaculum. The median nerve also passes posterior to the flexor digitorum superficialis, lies on the flexor digitorum profundus, between the superficialis and profundus, and in this location it gives a very important branch. This is the anterior interosseous nerve. The anterior interosseous nerve supplies the deep flexors of the forearm, which means the nerve supply. Now let's go back to the nerve supply. We've done the attachments, we've done the actions of all these muscles. Let's do the nerve supply now. Nerve supply of the flexors, we said median nerve supplies most of the muscles of the forearm, barring a few. We'll see which few now. So among the superficial flexors, pronator teres, flexor carpi radialis, palmaris longus are supplied by the median nerve. The flexor carpi ulnaris is supplied by the ulnar nerve. Flexor digitorum superficialis is supplied by the median nerve, main trunk of the median nerve. And in the deep plane, flexor pollicis longus and flexor digitorum profundus as well as pronator quadratus are supplied by the anterior interosseous branch of the median nerve. The flexor digitorum profundus, only half, the lateral half, is supplied by the median nerve. The medial half of this muscle is supplied by the ulnar nerve. So in the flexor compartment of the forearm, the median nerve, either directly or through its anterior interosseous branch, supplies all the muscles, all the flexors of the forearm, superficial and deep, except 1.5 muscles. What are those 1.5 muscles? They lie along the medial side of the forearm. The flexor carpi ulnaris in the superficial group and the medial half of the flexor digitorum profundus in the deep group. These are supplied by the ulnar nerve. All the others, the lateral half of flexor digitorum profundus, flexor pollicis longus, pronator quadratus are supplied by anterior interosseous branch of the median nerve, whereas the main trunk of the median nerve supplies pronator teres, supplies flexor carpi radialis, palmaris longus, supplies the whole of flexor digitorum profundus, and that's it. That's the main trunk. The rest are supplied by the anterior interosseous nerve. The anterior interosseous nerve is a branch of the median nerve given very close to the apex of the cubital fossa, and it comes to lie on the anterior aspect of the interosseous membrane between the radius and ulna, where it is accompanied by the anterior interosseous artery, which is a branch of the common interosseous artery, which is a branch of the ulnar artery. The posterior interosseous artery passes in the gap above the interosseous membrane here. The anterior interosseous, so let me go further back, this one. So here it is given off. Common interosseous bifurcates into anterior interosseous and posterior interosseous artery with respect to the upper edge of the interosseous membrane. Anterior interosseous artery comes down, posterior interosseous artery goes behind. The nutrient foramina of both radius and ulna get their nutrient arteries because the foramina are present on the anterior surface between the anterior borders and the interosseous borders of both bones. They get their supply mostly from this anterior interosseous artery. What is the nutrient artery of the humerus? Where is it located? What gives the nutrient artery to the humerus? There is only one artery in the arm. What do you think is the artery of the arm? Brachial. So that supplies the nutrient artery to the, but that is the usual. It's not always true. There is a lot of variation in blood vessels. But commonly in a majority of individuals, that's the pattern. So the posterior interosseous artery will go behind, anterior interosseous artery will lie here along with the anterior interosseous branch of the median nerve, and the artery will then again go back to take place in the anastomosis around the wrist through this gap, this aperture in the lower part of the interosseous membrane, the anterior interosseous artery. Okay? Whereas the anterior interosseous nerve will end in relation to the carpus after supplying these muscles, deep muscles of the forearm. So anterior interosseous nerve is the nerve of the deep muscles of the forearm. It is a branch of median, so we say median nerve supplies all the muscles of the forearm except the 1.5 medial muscles, flexor carpi ulnaris and medial half of flexor digitorum profundus. Clear? Nerve supply?
Yes, ma'am.
And the opposite you will find. There are 20 intrinsic muscles in the hand. That is why you are able to do so many fine motor skills with the hand. You can write, you can paint, you can do embroidery if you want to. You can develop these muscles. You can play music, musical instruments. You can thread the eye of a needle because there are so many muscles in this hand. And it's a big area of representation in the brain. 20 intrinsic muscles. That is apart from these forearm flexors which are inserting in the hand. And this is only for the palm. Dorsal aspect is separate. Okay. So I hope you are clear with the nerves and the blood vessels of the forearm. And near the wrist, I told you what all structures become. So all the major nerves and arteries are fairly superficial, just proximal to the flexor retinaculum. Now notice one other thing. In one of the diagrams it was there. These interosseous branches will pass posterior to the pronator quadratus. It's not here. I'll show you in another figure. So radial artery, the main trunk of the median nerve. This is the main trunk of the median nerve. Okay? And ulnar artery and nerve. So lateral to medial, it is radial artery, median nerve, ulnar artery, ulnar nerve. So the most medial is ulnar nerve. This is the relationship. Radial pulse can be palpate is radial artery is between the tendons of flexor carpi radialis. I'll show you the surface anatomy. And flexor digitorum, and I'll show you the surface in the next picture. I'll show you. Here this I showed you is just lateral to the pisiform but medial to the hook of the hamate. This is how they'll pass. So a recap of all the muscles. I hope it is clear. We still have 5 minutes, and in these 5 minutes, so these pictures show the arteries, and I have pictures for the distribution of the nerves as well. Radial artery, see, flexor carpi radialis, and the insertion of brachioradialis. That's where the radial artery lies. Ulnar nerve and artery lie here, between the pisiform and tendons of flexor digitorum superficialis superficially and profundus deeply. And what happens to them in the hand? This continues as superficial palmar arch, radial artery continues as deep palmar arch. Both arches are completed by branches of the other artery. So rich anastomosis all around at level of all joints in the upper limb. And the nerves, lateral cutaneous nerve of forearm comes from musculocutaneous, median, ulnar and radial. Median and ulnar supply the flexors of the forearm, but because we have a lateral compartment brachioradialis and extensor carpi radialis longus also in the front, so I mentioned radial. Okay, so the course of the nerves, and individually how these nerves go. Musculocutaneous, this is median, this is ulnar, and this is radial, the distribution. Now in the surface anatomy, I wanted to show you, this is where you palpate between the tendons of brachioradialis and flexor carpi radialis. You can palpate the radial artery pulsation. You can also palpate on the medial side of the wrist the ulnar artery pulsation by pressing it against the lower end of ulna, or more distally in the hand by pressing it against the hook of the hamate. This is the tendon of palmaris longus. This is the tendon of flexor carpi radialis. So the tendons of the superficial flexors can be seen, and this bulge between the tendons is due to flexor digitorum superficialis. And where will the median nerve be seen? It will be seen medial to the tendon of flexor carpi radialis, between it and palmaris longus superficially, or between it and flexor digitorum superficialis at a slightly deeper level. So these are the sites where you palpate the various peripheral pulses. This is not so easy to palpate. You know, the axillary artery is the toughest to palpate. The brachial artery can be palpated by pressing the brachial artery against the middle of the shaft of the humerus, very close to where the teres major inserts. So almost at the lower edge of the axilla, just where it begins as brachial artery. And it is auscultated medial to the tendon of biceps here. It can be on deep pressure palpated here. This is how you palpate the radial pulse, and you can also palpate the ulnar pulse. So the method of palpation is shown. Palpation of peripheral pulses is extremely important. This is the most important part of surface anatomy. With every part we do surface anatomy. So it's less important to know what points to mark structures on the surface of the body. It is more important to be able to palpate palpable vessels and palpable nerves and bony landmarks. And why do we do surface anatomy? Surface anatomy is the basis of physical examination and planning of surgical procedures. All the clinician who examines you, the physician who examines you, makes use of surface anatomy in order to locate deep structures, right? To get an estimate about deep structures. Similarly, surgeons, when they are planning surgical incisions prior to surgery, they may make use of bony landmarks. Okay? Now, this is hand territory. There is something called anatomical snuff box. I don't know if you can see this depression. Can you see this depression? Can you? When you fully extend the thumb, the tendons here stand out and there's a slight depressed area. Can you see? Anybody can see? Can you?
Yes, ma'am.
You can do it yourself. This little dimple that you see here, this is called anatomical snuff box. The radial artery, after passing next to the lower end of radius, then enters this and can also be palpated against the bones that form the floor of this triangular region. You will do this with hand. Okay? And I've already talked about how we take the blood pressure reading by palpating the tendon of biceps and placing the diaphragm. This is called the diaphragm, the part which is in contact, and this part is called the bell and diaphragm of stethoscope. The one which is above is bell, and the one which is in contact, the wider part, the diaphragm of the stethoscope, just medial to the tendon of biceps, which is the surface location, surface anatomy of brachial artery in the cubital fossa. So all the surface anatomy is plotted here for all the major nerves and blood vessels of the entire limb. Flexor aspect, anterior aspect only. So you can make use of these, and now the lecture theatre attendant is going to start making noises. So I have to stop, but I want to show you the videos which we have recorded of the axilla from our dissection hall specimens. So our residents have done it. Senior resident Dr. Nidhi along with other junior residents, Dr. Jayashri, and helped by the other senior and junior residents have recorded these videos. See if you can identify these structures. And I will stop after the videos. So they are not in any particular order. Just see if you can identify the structures. These are from our dissection hall specimens. What is this? What is this, anybody? What is it? What is this structure which I am pointing at? Bicipital aponeurosis. See, it's going all the way to the posterior border of ulna. You're looking at the cubital fossa from the side. This is biceps. The tendon has a deeper insertion. See, she's retracting it. Very good videos have been made. So this is the tendon, what she's trying to retract. What muscle is this which she is retracting? What muscle is this? Brachioradialis, correct. What muscle is this which is being crossed by the bicipital aponeurosis? What muscle is this? Correct. So and now see, in the arm you can see these structures coming down into the cubital fossa. Basilic vein is visible. Artery and nerve are also visible. Now we'll see the next video, because this was from the side. Forearm flexors and cubital fossa. Now you can appreciate, line passing through the epicondyles is the base. This is the lateral margin. This is the medial margin. The two heads of the pronator teres, so clearly seen. Can you see this? Two heads of pronator teres. And the median nerve passing between the two heads. Can you appreciate my cursor?
Yes, ma'am.
Okay. So what is this structure then? This is brachial artery. And dividing into, bifurcating into, this is the superficial radial artery which passes into the groove between the brachioradialis and the pronator, and further proximally, further distally, it will pass beyond the pronator. And this is the median nerve. What is this tendon? What do you think is this?
Interosseous ligament.
No. This, it's coming from here and going here. This is the tendon of a muscle. And it is medial. Brachialis, excellent. This is the tendon of brachialis on the way. This is forming the medial part of the floor of the cubital fossa on its way to the ulnar tuberosity. Because remember, tendon of biceps has to be lateral to the brachial artery. So this can't be tendon of biceps, isn't it? So here, this is biceps. This is brachialis. The aponeurosis has been divided. So ulnar artery going deep to the deep head of pronator teres, radial artery going superficial. This is brachioradialis, this is extensor carpi radialis longus, sorry. I think I moved to the previous video. I don't know. No, it was correct. Sorry. Yeah. I clicked, so I thought maybe I've gone. Yeah, so here we were here, right? So this is brachioradialis all along going to the base of the radial styloid. This is extensor carpi radialis longus. It's going into the hand. Now pronator teres seen again, two heads. This is the tendon of biceps. The aponeurosis has been divided. It's going to the posterior part of the radial tuberosity. This is lateral, this is medial. Medial epicondyle is more prominent. Two heads of the biceps. So biceps remains separate for a very long, only just proximal to the tendon, the two bellies unite. Yeah, now this is the radial nerve. See this? It's between the brachioradialis and on a more deeper plane, the brachialis. Superficially, it seems to be between the biceps and the brachioradialis, radial nerve. Dividing into its superficial branch, this is the superficial branch, and its deep branch, which passes between the two origins of the supinator. So this is supinator forming the floor of the cubital fossa. So the superficial branch goes deep to the brachioradialis, and further distally we will see it. Tendon of biceps. This is brachialis. So now you've seen, better than the pictures, you've seen the floor of the cubital fossa. Now this is the deep branch, posterior interosseous nerve, deep branch of the radial nerve, which passes, supplies the supinator, passes through it and goes to the back of forearm. This is brachialis being shown. Now here I would like to mention one fact. Oh, again it's come. Here I would like to mention one fact. The radial nerve. Now the motor nerve supply to coracobrachialis, biceps brachii and brachialis muscle comes from the musculocutaneous. But radial nerve in this location, in the distal forearm, in this location which is between the brachialis and brachioradialis, the radial nerve sends some proprioceptive or sensory fibers to the lateral part of the brachialis muscle. So brachialis muscle has a dual nerve supply, although its motor supply comes from musculocutaneous. So its prominent action at the elbow joint will not be affected in radial nerve damage, but it will definitely be greatly weakened if the musculocutaneous nerve is damaged. Is that clear? So biceps, tendon of biceps. Always remember, artery is medial to tendon of biceps. So here you can see the brachialis also, and this radial nerve coming anteriorly for a short while only in the region of cubital fossa, and then its superficial branch is going down deep to brachioradialis, but the deep branch pierces or goes through between the heads of supinator and goes to the back of forearm. Deep branch. After supplying a branch to the supinator. This is supinator. This is superficial branch of radial nerve, which at the wrist you will find it will go with respect to the ball of the thumb, thenar eminence base, then it will go to the posterior aspect. I think it is clear now, isn't it? These are very good quality videos. So these are real specimens which you would have seen if you had come to the dissection hall in better times. Hopefully you will get to see before your prof. So next video, bas ho gaya almost. I just finished the videos. Okay, now the superficial muscles have been partitioned. So what you're looking at, you can see a bit of the interosseous membrane. Here this is the flexor digitorum superficialis muscle. It is divided from its radial origin. So the superficialis muscle, see how the tendons are splitting on their way to the middle phalanx, and this is the profundus tendon. What she is holding now is the profundus, and see the hammock it forms posterior to the profundus tendon. Okay, clear? Now it's clear? It's going to the distal. Now the superficialis
Yes.
has been divided also. Now you are looking at the profundus. This is a flexor digitorum profundus. I'm sorry. This is the flexor pollicis longus. It's a unipennate muscle. This is flexor pollicis longus. I'm sorry. Fatigue has set in. The flexor pollicis, you can see the unipennate arrangement. Now the reason why we tell you not to mug up the examples is because you'll be doing every part and then you can see which one is unipennate, which one is bipennate, which one has parallel fibers, and then you'll remember it better. This is the pronator quadratus. So that is flexor pollicis longus, interosseous membrane, interosseous nerve going posterior to the pronator quadratus, and this one here where my cursor is flexor digitorum profundus. This one. And you can see the ulna here. You can also see the anterior interosseous artery next to the nerve on the interosseous membrane. Excellent dissection. Both structures you can see going deep to pronator quadratus. Clear? This is the ulnar nerve. What she's showing now is the ulnar nerve, and because now the superficial muscles have been removed, so you can see the ulnar artery also. And this is the median nerve. So we've removed the superficial flexors to show the deep flexors, and this is the radial artery. This part we can leave. This we'll do tomorrow. So I'm stopping now. I hope I tried to make it as simple as possible. It's a tough region, but once you learn it and you learn it logically, it should not be so difficult. Thank you for your patience. I'm now
Ma'am,
stopping.
will our offline classes start?
When will your physical classes start, you mean? Huh?
Yes,
I don't know. Whenever they have to start, we'll be notified. So far, we have the online schedule for January. We are making them 1 month at a time, hoping for better times. So till January end, the schedule has been uploaded on Saral. Okay?
thank you.
And any queries you are most welcome to ask. Any clarifications you ask in the group. Okay, right now it's already 10 past 5, and I think a large number of people have already left. I don't know. Okay. Substantial chunk has left. There were 150 abouts and now they are close to 110. So I will stop. Are there any questions in the chat box? I don't know, I didn't see it. I never look at the chat box while I'm speaking. It disturbs my flow. I think we've answered most of these. The best diagrams for reproduction are Snell's. Sayak has asked, the best diagrams which you can draw from are Snell's. Netter's he was an artist. He was an anatomist who was an artist. I don't think you should even try for Netter's. You can understand using Netter's. And I believe there is one student in your batch who made diagrams like Netter's Atlas. I was quite impressed. I think everyone else is saying thank you. So this is my cue for now stopping and getting lost. Thank you.
Thank you, ma'am.
Okay. ये कन्वर्ट रिकॉर्डिंग आप करोगे ना, मेरे को तो नहीं करना ना. कन्वर्ट रिकॉर्डिंग ये बोला है कि दे नीड टू बी कन्वर्टेड. वो अपने आप करेंगे. हाँ, ये मैं निकाल रही हूँ और इनको मैं डाल रही हूँ अंदर. ओह अच्छा, ये खुले हुए हैं, इसको बंद करना है.
वो मैं क्लब करूँगा.
एक मिनट, वो तो आप कर लेना, मेरे को अपना करना है बस. अच्छा, अब आप करो। थैंक यू। बड़े बड़े टॉपिक्स होते हैं, क्या करें हम भी। बैठे बैठे 3 घंटे लेग्स भी स्टिफ हो गई।